Good morning, everyone. Nice to see all of you. Welcome to the Fielding School Research, Innovation, and Impact Day. I'm Ron Brookmeyer. I'm Dean of the UCLA Fielding School of Public Health. And thank you all so much for joining us today. So this is the second time we've held this event. The first time was 3 years ago. And a lot has changed in the last 3 years. First, we have some terrific new faculty who have joined our school, and you're going to get a chance to meet them today and find out some of the interesting things that they're working on. And the second thing that has happened is the landscape for public health has changed a lot. There are a lot of new challenges that we face. And we are going to get to hear from someone who's on the front lines a little bit later this morning, Dr. Erica Pan, who is the director of the State Public Health Office for the California Department of Public Health, and she'll deliver our keynote address later this morning. So the vision of today is it's an opportunity to share information with each other and have conversations, to network about some of the impactful research and practice work that's happening at our school. And it's our hope that this will provide opportunities to spark new conversations and maybe even new collaborations to address some of the critical public health challenges that we face. So the way we're organized today is we have 4 panels. Each panel is going to have presentations and a Q&A session after the presentations. And the 4 panels are organized around 4 themes. So we have artificial intelligence and data science powering public health, combating chronic and infectious diseases, championing health equity, and protecting health in a changing physical environment. Also, please make sure to have a look at our the finalists from our Student Impact Poster competition, which are on display in the lobby. And students during lunch will be standing next to the posters, and you can ask questions and have a chance to interact with them. So please be sure to stop by. And we will announce the student finalists right after lunch here. And we'll also be including which of the 2 students are the recipients of the Lester Breslow Impact Fellowship, and that'll be right after lunch in this auditorium. So I hope you'll stay with us throughout the day, which includes lunch, and at the very end, after our last formal reception, there will be a formal presentation, last panel, there'll be a reception outside. In the area right outside the auditorium. So now before we get started, I have a few important thank yous. I want to thank our program committee who put together today's 4 panel sessions. Professor Kate Crespi, Beth Glenn, Rachel Jones, Michael Prelip, and Xiaofeng Zhang. So thank you to our program committee. And a very special thank you to our event planning committee and everyone who has worked very hard to make today's event possible. Jennifer Powers and the entire Development and Alumni Affairs team, Janet Hung, Rebecca Wolf, and Carla Denley and the entire marketing and communications team, thank you so much for everything you've done. And last but not least, a very special thank you to Professor James Masinko, who is our school's terrific Associate Dean for Research and a professor in the Departments of Community Health Sciences and Health Policy and Management. And it's been my privilege to partner with James in making today's event a reality. And so without further ado, please join me in welcoming Associate Dean James Masinko.
Thank you so much, Ron. It's really great to see all of you here today. I am so excited and energized by this event, and I hope that you will be as well. Before we dive in, I have a couple programming notes for you. If you haven't already done it, you can download the program using the QR code up here. I ask that you please keep your phones on silent. Thank you. We're recording today's event so you can watch it again. You can send it to friends and family, and we hope that we'll be able to make good use of these videos showcasing our faculty's research and practice experiences. Each of our panels will follow a similar order. The moderator will introduce and invite up the panelists. The panelists will each give a short presentation. Then we'll have time for questions and answers. During that time, we have folks who will be circulating the halls, the corridors with microphones. If you want to ask a question, just raise your hand. The microphone will come to you. In the interest of time, we ask that you be direct with your questions. So, we also have built in a couple times breaks as well as other moments for you to be able to connect with each other, to learn a little bit more about what each other is doing, and hopefully to spark some new collaborations. So I'm now excited to kick off our first panel. And with that, I'd like to introduce our moderator, Dr. Philip Massey. He is the Vice Chair and Professor in Community Health Sciences. Thank you.
Thanks so much, James. Well, it's truly an honor. It's great to be here today to kick off this important event and the first panel addressing artificial intelligence and data science powering public health. In recent years, there's been an incredible explosion of available data, and if utilized in a responsible manner, can really advance public health. Today, we're going to explore with some experts how to utilize data to prevent certain public health crises, address problems, and overall improve population health. So as James mentioned, we'll have 3 experts present, each of whom will speak for up to 7 minutes, and then we will open the floor for a very exciting Q&A. So I'm excited to start today with Dr. Scott Camulata. Dr. Camulata is a professor in the school's Department of Health Policy and Management, and also in the UCLA's Department of Psychiatry and Biobehavioral Sciences. So please join me in welcoming Professor Camulata.
Well, thanks so much. I'm excited to be here as well. And I'm just going to add to the thanks to Ron, as well as our dean, for supporting this event too. And just happy to see all of you. Thanks so much for being here. Thanks a lot. I also want to acknowledge NIH funding and all the wonderful research centers at UCLA supporting this work. So when I think of AI and public health and healthcare, I like to think about 4 buckets. And my fellow panelists are going to be talking about more AI on the research side. Certainly the research changes how we teach, changes the content, changes what we teach. I certainly used AI to make this infographic, for example. Also changes how students learn. And I'm going to be talking about how chatbots are changing how students learn in the clinical setting. Also changes how we deliver clinical care. And I'm also going to be talking about how chatbots change that. So I'm going to be focusing on those 2 topic areas. Got it. So first case study, clinical care. I want to acknowledge my fellow faculty members in this, Lillian Gilberg, Dallas Swendeman, and I talked to Roxana earlier, one of my favorite postdocs. She's involved in this too. We developed a rule-based bot. We pivoted to a large language model bot, and the purpose was to support patients in treatment for substance use disorder in between visits with their peer recovery coach. So what I'm showing on the slide here is a screenshot of me interacting with the bot. You just text message it. It's named Susie. That tested well with the user groups. And it's got a nice user interface. It's got many features, but one I want to highlight, it acts as a health coach. So let's say, for example, it's late at night, it's the weekend. I can't really talk to anybody, but I'm having strong urges. I don't want to relapse. Susie acts as a health coach and gives you urge surfing techniques other techniques to deal with that. Now, of course, we're in a public health space. We want to think about health equity issues, safety with AI. We don't want to just release an AI bot. What do? Well, this development process started with a lot of iterative testing. And like everything, it started with bringing the right people to the table. The whole spectrum of knowledge users, from addiction medicine specialists to peer recovery coaches to the patients themselves. What features did they want? What did they want to see? And that really fed into the chatbot's architecture. Now, in the interest of time, not going to go into details, but what I want to emphasize in this slide is that at the first layer, when a person interacts with the bot, the input as shown up here, before anything else happens, that conversation gets routed through an agent that acts as a safety layer. And it checks for any language that possibly indicates suicidal ideation, suicide risk. These are former substance users, so they could be experiencing withdrawal symptoms, need medical care. So that was first and foremost on our minds and refined with this iterative work. I'm going to now transition to another chatbot use case, this time on the virtual or clinical training side. If we think about how we train our practitioners to interact with patients, there's really 3 tiers. It starts in the classroom, there's role playing. Standardized patients are very important. These are actors that act as patients. And of course, there's clinical rotations. But there's a big limitation with resources, time to do these things during training programs. So this led my group and I to think about, can we develop AI tools so students can practice anytime at home using a computer interface? Again, important work with colleagues, many multidisciplinary, Patty Gans, Lillian Gelberg among the colleagues. And we developed a Breaking Bad News scenario. And the idea here is that you have a patient who's gone for a screening mammogram, shows an abnormality. They then go for a diagnostic mammogram. Thank you. Shows an abnormality, and now they have to go for a breast biopsy. Obviously, this is very unsettling for the patient. They want to talk to their primary care physician, which is you. You are role-playing that. So the simulation role plays, you're talking on the phone to your patient, and you go through this conversation with them. We pilot tested the bot with medical students. This is showing one of our collaborators, the UCLA Simulation Center, in one of the rooms. You sit in front of a computer, you speak into the computer microphone, the LLM recognizes and converses with you. The students were very excited, had positive outcomes. Showing 2 screenshots. One is just the interface you use. This patient's name just happens to be Olivia Patterson. You click on it to talk. I want to highlight the screenshot on the right-hand side because this is not just a simulation, but it gives you feedback. So feedback is a crucial part of improving your communication skills, and that's something that AI has struggled with. It tends to be a sycophant and tell you what you want to hear. We actually prompted it to give critical feedback, which is what the students really wanted. I'm at time, but I'm going to do, thanks so much, Eric. I told Eric he's my new best friend this morning. He's helping me out I'll keep it to like a 10-second. I realize I have 30 seconds left. I just want to demo the clip here of me talking to this simulated patient. Not a clinician, probably use incorrect language. That's my disclaimer. But let's see if this works here. We can turn the volume up just a little. It's going there. Okay. Hello, Mrs. Patterson. This is Dr. Smith. I was returning your call about your mammogram results. Is now a good time to speak?
Yeah, I'm here. Can we talk about what's going on with that result?
Yes, absolutely. Let me first ask, what was your understanding from the message you got about your results?
Honestly, it sounded like they found something suspicious, but I didn't get why a biopsy is needed right away.
Yeah, absolutely. So what it means is that on the image,
I just wanted you
they
to hear
did
the
see an
voice and kind
area
of
of
how
the
it
image
reacts
that
to you. But you can
they
check
can't
on
quite tell
there was
what
a
is
QR
there.
code link. You can see the full video there. Thanks so much for your time. Thank you. Thank you. Really appreciate it.
Well, thank you so much, Professor Camulata. That was fascinating and a great kickoff to see really some great applications for this technology. So now it's my pleasure to welcome and introduce Dr. Sijia Lee, who is an assistant professor in the Department of Biostatistics. She's going to be making her way up here while Eric helps get the slides back up. And if you could join me in welcoming Dr. Lee.
Good morning, everyone. I'm really excited to be here. My name is Sijia. I'm assistant professor of biostatistics. I just joined last year. So I'm super excited to be here. Thank you for everyone who made this possible. I know I only have 7 minutes. I don't want to self-introduce anymore. So I'm very happy to share some of my thoughts on, how do we make AI useful, especially for public health in this world of scattered data. So if you look at the data structure in public health, the problem is really that we don't have any data at all. Despite that the data is exploding, the problem turns out to be always we don't have enough data. And then why? Well, it can be helpful to look at the data collection process at the beginning. Well, these data sources arrive at different times, especially for clinical outcomes. They may be measured in different scales or evaluate according to different criteria. If I run a multi-site RCT, these data are collected across different hospitals, different centers, different systems. So to give an example, this Alzheimer's Disease Neuroimaging Initiative, ADNI, this is an amazing effort, observational study, multi-center coming across different centers, spent over 20 years plus. And then if I look at the data, immediately 2 keywords pops up. The first one is incomplete. So this is beyond, the normal patient loss to follow-up. Instead, entire block of data is missing. So if you look at everyone enrolled in the first phase, ADNY1, they don't have their gene expression data measured. The reason is simply because back then, 2004, the technology isn't just readily available yet. The other keyword that pops up in my head is heterogeneous. So all of these different phases belong to the same initiative, but every time they try to recruit a slightly different target population. So at the second phase, they're trying to deliberately recruit more patients who are already, had a mild cognitive impairment at the baseline. To give another example, we used to work with youth suicide risk prediction. The data I work with is EHR data from Mass General Hospital. Mass General Hospital is actually one of the 7 practice-based suicide prevention research centers launched back in 2020. This is a very amazing opportunity for us to especially address questions for underrepresented groups. These are the people who are underrepresented in the data, so you need more sample size in order to answer questions for them with enough precision. But what's the big challenge? Well, the data, although you have more sample size, is distributed across different centers and institutes. So given that, that's a very quick overview of the data structure. I think the most important fundamental question for AI is, of course, can they predict well? But I think it's equally important to ask this question. That is, can we use AI in a reliable way, especially when evidence is actually not complete, given that we have seen these data are incomplete, they're heterogeneous, they're also distributed. So that's why I think the following 3 aspects comes very important, which is the evaluation of AI models, the calibration of their outputs, and then finally, how do we coordinate the implementation of AI models across systems. So speaking of the first one, this is what we might have in mind when it comes down to evaluate AI models. We have a list of models. We sort of assign them a score, rank them, which comes the best is the whole story. So this is MetQA. This is another group's amazing work. It's sort of a curated data set. multiple choice type of, think of this as a quiz. I fit this into the ChatGPT or, different AI models. Let's do it a quiz. And then I think I figure out how much I get out of. Right, so this is what the story tells us. The MatQA tells us one story, which is the ChatGPT 5 appears to lead. But the question is one data set the whole story? Well, it could be, if this curated data set contains every single piece of knowledge that people have compiled over the entire human history on medical field, right? So they ran this for another two different data sources, the PubMedQA and the MCQA, and then you see there's a variability in AI model performance, and then this is very common. You also see this variability across contexts, research domains. So this is the central problem with incomplete data. If you just evaluate AI models using one or under one setting, you never got to see the whole picture. You may mistake one sort of local success for general reliability. And then it's especially risky in public health because, a lot of times decisions are made across different populations. They are made across different clinical contexts. So we try to provide a principled way where biostatistics will try to model it in a very flexible way, trying to account for the variability in this performance. So this is my collaborator, Shudi from UC Berkeley Biostatistics. Okay. So after evaluation, well, given that AI models, if it's 100% perfect, we're very happy. But if not, what should we do next, or what are the possible next steps? Well, one of the things could be the calibration. So one example, suppose we're trying to identify heat-related emergencies visits during a heat wave. When I think about problem, I think about a data structure. So here is a list of patients I have. For every one of them, I have the features. These could be diagnosis code, lab results, every reach, summaries, discharge summaries. And I just fit every features into this AI model, come back with a prediction whether it's not or likely heat-related visit or not heat-related. It's real time. Sometimes it's really hard to be real time, but that's good. It's cheap, hopefully, and easy to deploy. But the problem is it's reliable. Right? So one intuitive, solution is trying to calibrate them, given that we can collect a truth. So the golden standard label, which in this case is actually heat-related visit or not heat-related visit, for just a subgroup of the patients, and use those truths to trying to calibrate the prediction models by the AI. And then this is nothing new. This is a really well-known sort of approach called LLM as a judge evaluation. And then this work, I'm working with my collaborators, Yichuan and Siju from Hopkins and Berkeley. We propose an efficient inference procedure for this noisy LLM as a judge evaluation. And finally, we haven't set foot on this one, but I think it's great future revenue, is how this AI can help with federate methods, which can actually let different sets collaborate without sharing individual level data. So instead, they share summary data. And I think the reason why is AI can actually help learning more sort of portable representation across sites, and therefore facilitate the collaborate learning. So I'm just going to end with, maybe it's too small. So I asked AI to generate a figure to end my talk, and then not very successful, but I want to end with the idea that I do believe AI tools can serve sort of as a bridge for these fragment data, but the question is we need to use this reliable way. Thank you very much.
Thank you so much, Professor Lee. So we're moving from cases and chatbots to model evaluation and calibration, now to introducing our third and final speaker in this panel, Dr. Joanne Elmore. Dr. Joanne Elmore is a professor of health policy and management in the Fielding School and a clinician and professor of medicine in the Division of General Internal Medicine at Geffen School. So please join me in welcoming Dr. Elmore.
My goal is to help you build a healthy skepticism about AI. I'd like to start with a clinical case, and it's about diagnostic accuracy. We have a problem. I'm a physician, and this is a personal story. Over a decade ago, I had a skin biopsy. I was called, told I had invasive melanoma. We got a second opinion. I was told it was normal by the second pathologist. We then called a world expert, please look at my slides. They said it was just a complicated Spitz tumor. 3 pathologists, 1 skin biopsy. This is not just a personal description of variability. This is a systemic issue and a challenge we have in the practice of medicine. It truly is an art. That's why I love being a physician. So this wasn't just my case. I've studied the variability of clinicians, and this is an example of 1 skin biopsy shown to 36 practicing pathologists, not medical students. These are people actively interpreting your biopsy cases. Look at the range, and only 10 agreed with our expert consensus diagnosis. So, given these challenges, AI has been proposed as a solution. For the last, I know you're laughing, but seriously, for the last decade, I've been working with engineers, and I give them the data shown on the left. I give them this image data. Then they do region of image detection and tissue segmentation, and they spew out a diagnosis. A decade ago, my postdoc students in engineering were giving an accurate diagnosis on par with US pathologists. But in the process of working on model development, there are a few areas that really bother me. The first is, how do we define a gold standard? Were my 3 experts enough? Do I need 5 experts to define the gold standard? Second is the black box transparency issue. I have a new grant where I'm going to add pathologist in a loop so I can try and understand what's in that black box. The final area is generalizability and bias, and it's so important. I want to just describe this one example of racial bias. This was an algorithm in use on hundreds of thousands of patients in the US. The algorithm was biased because it used health cost as a proxy for health needs. Patients were harmed. We need to have multidisciplinary teams. We can't stay in silos with the engineers over here. We need public health experts and clinicians to also be involved. There's one final area I'd like to cover, and it's the human-computer interface, because we humans don't always interact with AI and computer things the way you think we will. I became interested in this topic when I was working at a county hospital, and a patient asked me why they were charged extra for a computer to read their mammogram. It's a great question. I had been working in mammography and accuracy. I had access to hundreds of thousands of mammograms, half interpreted with the computer support tool and half interpreted without. I could compare accuracy. This shows our findings. When the computer was introduced, we expected accuracy to get better. It didn't, it got worse. When the computer was used in a real-world clinical setting, not just in the test set to get FDA clearance, somehow it was associated with significantly lower accuracy. And it was what happens in real-world clinical practice. I hypothesized that there are a few potential human-computer reasons for this. First is automation bias. This is going with whatever the AI says. We clinicians care. We don't want to miss anything. If the AI prompts and says there may be an abnormality, we'll call the patient back. There could be a lot of false positives in there. On the other hand, we may get falsely reassured and start trusting the AI. Nothing's perfect. We may miss things that we normally would have caught without the AI tool. Secondly, de-skilling. This is really scary. We are losing our underlying diagnostic skills and acumen as we rely more and more on AI, especially the med students and residents that are currently being trained. We need to learn how to teach with these tools. As I was typing my notes for this talk, my autocorrection changed de-skilling to doctors killing. It's maybe an overstatement, but it is a real concern. Okay, now my final comment is just the intent, and are they helping? We like to play around. We've got technophilia in our society. And this leads me to describe some of my current projects. I'm just starting leading a pragmatic randomized trial looking at whether AI helps in a real-world setting in screening mammography. It's recruiting from across the US. Our target enrollment is 400,000. And we want to really see, is it helping? The second study that I'm also just starting is a bit more granular, looking at how the humans are interacting with the AI. For example, on the left, you see, should the AI just point out an area on the image, a feature area, or should it give you a diagnosis and say this is melanoma? On the right, you see the timing of the AI cue. In current clinical practice, all of the AI cues are given to us before we have even looked at the data. And that's what we're studying in our big 400,000 trial. On the bottom, it shows you that we're studying to see whether maybe we clinicians should look at the data first, create an independent interpretation, and then see if we want to change it with the AI data. Now, this second study also is working with cognitive psychologists. And so we're looking to see when you have these different AI cues, how does that change the viewing behavior time and where they look? So I'm looking at the clinician decision-making process, and I really care and hope that the AI is helping. In summary, I think there's enormous potential from the AI tools. I hope that they will lead us to improve our diagnostic accuracy. I only had 7 minutes, so I didn't even share with you that in one of our studies, we gave pathologists the same cases. We kind of reshuffled them and renumbered. They didn't know they were the same cases. 40% of the time, they changed their diagnoses of melanoma. So I am hopeful. Secondly, the question is not whether AI works, but whether it works with the human and interacting and supporting us. And then finally, while the AI tools, they've got this great potential, we can't forget we need multidisciplinary teams, public health clinicians, and the engineers working together. Rigorous evaluation. We have to ensure that it is enhancing, not disrupting clinical care. Thank you very much. It's an honor to be on this panel.
Thank you, Dr. Elmore. Could I please invite all of our panelists carefully to stand up on the stage and take a seat at the very fancy director chairs, which are very nice. So now it's our time to get involved as an audience. And when I call on you, if you could please stand, you could state your name and then ask your question. So who would like to go first? Dr. Masinko, or you can stand and state your name.
James Masinko. I'll say it into the microphone so that it's recorded. I think one of the things that, at least as kind of a consumer of AI that I see, is that these models are developing so incredibly rapidly. I'd love to hear from the panelists how you incorporate that into the approaches that you use in kind of testing and assessing the utility and effectiveness of these tools.
It's a major problem. We need all the brain trust in this room to come up with new methodology. I described a prospective randomized trial. This is going to take me 2 years. And AI is changing week to week. In our analysis, we will be looking at AI model version as the sites update, as we're recruiting 400,000. But it is an issue.
Excuse me, just to piggyback on what you were mentioning, Joanne, for Susie, the chatbot, this happened to us where the older model was being deprecated while we were in the field working with patients. So one of the things we had to do was scramble, and with our testers, we did a randomized blind experiment where we showed some testers messages from the new model, messages from the old in response to questions for Susie, and asked them, which one do you prefer? And so we kind of did it that way, and we had to change the prompting, the fine tuning of the model to make it fit to respond the way we wanted to.
Speaking of the evaluation of models, I have a very simple answer. It's just, whenever a new one comes in, we fit the model again. But the way I think about it is it's a hard question because it's like a basketball game. You have new players coming in. And then, one way out is trying to, of course, impose some kind of assumption. ChatGPT 5 or 6 definitely outperform ChatGPT 4. And then in that way, you can try to simplify the problem by comparing less pairs. But that, of course, come with assumptions and costs. But it's not an easy problem.
We have Dr. Afifi.
Okay, thank you. My question actually has to do with how AI will be or could be affecting our teaching curricula at universities. With artificial intelligence making a lot of what we do replicable by a machine, how can we adjust what we do to teach students who are the professionals of the future how to work with AI and not become obsolete?
I'm a practicing physician, and I see patients in the clinic. The medical students and many of the physicians are using Open Evidence. It's an app on my phone, only available to physicians. And I can basically enter all kinds of information, and it will tell me what to do. It's going to have ads. Yeah, you know how that's going to change our behavior. And I am realizing that we, older generation of clinicians, need to learn how to use these tools with the current generation. And we need to, as a group, collectively, think through how we are using them. Some of the AI models are recommending too much testing. They don't want to miss things in the early versions. And so my first comment on education is that we can't ignore, and we need to learn how to collaborate with the AI support tools. Then I am also starting to use a new app on my phone called Nabla, and it will, with my patients, it translates. It's an ambient scribe. And so when I go to look at my clinic notes, they're written, but there's errors. And so I need to point out the errors to my students. If there's a wife and the husband in the room with me, it may pick up and say that the patient has diabetes, but that was just the husband trying to talk over his wife, and he's the one with diabetes. So I have to make certain in teaching that I point out problems. We have to be careful in clinical practice. There's also a really cool new summary in the electronic medical record. We use Epic. Almost 95% of the health systems use Epic, and it's a paragraph summary. And it summarizes the wealth of all that depth of the junk in the EHR. I like it because it will have a reference, like a number, and I can look at a sentence to say somebody had a cardiac echo, and it says a 4. I can click on that 4. It will bring me to a 272-page PDF that I normally would have had to scroll through 274 pages to find the results of the cardiac echo. But it's not perfect. I was using it 2 weeks ago, and it told me a patient was pregnant. She was 64. I mean, this was like her old history. So my comment for this is that we all need to be learning, all the generations.
Yeah, thanks. I agree completely. And just to add to what you were talking about in the clinic setting, even just in the classroom as we teach public health classes, we need to understand the benefits and limitations ourselves. And I know it's hard, but we really have to dive in. And I think just giving the example, I have a 12-year-old, so I'm teaching her how to use AI responsibly. And of course, if left to her own devices, she'll just ask it to write a report for school. or to do her math problems. And she quickly discovered, wait, it got something wrong. She said, it lied to me. She was so heartbroken. And so kind of teaching her that, no, you can't use it to do things for you, but study mode is great. It can teach you in some ways that I can't. So I think us as professors learning how to use it ourselves, and I see signs of this already. I think Fielding is on the right track, learning how to use it responsibly, not to do things for us or everything, but to help us and enhance what we're doing.
So I use AI every day. I use AI for this slides. I use AI for my research. It's not good at generating sort of research ideas, but it's good at doing a literature review. So for me, I think it's helpful to think of which aspects of the AI can actually help the students. So I teach biostatistics. There's math, but there's also the public health aspect of it. There's writing. For the math, I think one easy way out is I try to put everything I want to test students for in quiz, so there's no AI. But for writing, it's especially harder, and I think writing is thinking. So it's very important to learn how to write. I'm not a native speaker. I learned how to write and talk through trial and error, through this hard process. So last quarter, I taught a class in designing clinical trials. So students have to write a SAP for the final project, and then I found it's very challenging because at the one time, I helped them to use ChatGPT for editing or rephrasing or try to polish what they have in the end. But on the other hand, I do need them to sort of maintain the critical thinking a bit. Don't let ChatGPT do the design for you. You need to brainstorm yourself. But I think it's just a very hard situation, and I think everyone's trying to figure out a better way.
I forgot to state my name. I'm one of my professor emeritus of biostatistics, Canteen Emeritus.
Thank you, Dr. Afifi. Another question. Yes, we have two questions over here. We'll take Curtis.
Hello, my name is Curtis. I was just wondering, I'm a current public health student here at Fielding. I was wondering, how are y'all managing the perception, like the public's perception of utilizing AI as a tool, right? Because in my current cohort, there are like people's concerns with using AI because of environmental concerns, and as well as like maybe like a patient might be concerned that like their doctor is like using AI, or someone might be concerned with talking to an AI chatbot instead of like a real person.
Our randomized trial is funded by PCORI. So we have patients, stakeholders, and patient advisors and patient collaborators. And one of our specific aims is to do focus groups with the patients, both at the beginning of the trial, but also at the end when we have the results, to see what their thoughts are on the use of AI.
Yeah, I'll just add to that. I agree with you. And Curtis, to your question specifically with chatbots, it involves bringing the patients to the table from the get-go. So they help us design it. When we roll it out with other patients, we can say, hey, patients are currently using this. And the patients are advocates themselves. And we're always very clear that you are talking to a chatbot. We don't want to trick anybody, so people understand. And if they don't want to use it, we don't want to force anybody. It's kind of like now if you go to your checkup, the physician at UCLA will ask you, can I turn on Ambien Scribe, during the visit? And some people might say no, and we want to respect that, and others are okay. So I think it's kind of adapting to people's comfort level.
My name is Masoud Agahi, and I'm a practicing physician myself. I'm actually a vascular surgeon and graduated from the executive MPH program here at UCLA only a few years ago. When I decided to go back and enhance my medical education with public health education, which I felt a real need for. And today I'm seeing that this issue of AI is really reaching a level of significance that I'm a little bit surprised that the FDA is not more involved in looking into this and setting standards. As I speak, I have a patient in the intensive care unit came in 2 days ago in the emergency room with an acute abdomen. And I was taught in residency, in a clinical picture like that, there's no questions asked. We don't even need to get an x-ray, you go to the operating room. But I'm a vascular surgeon. It was clear the patient happened to have an aneurysm, but this was not the real issue. Everybody got confused about the aneurysm, was missing the acuteness of the situation, which was related to a perforated peptic ulcer. Went back to the radiologist, please, give me something. And they're like, well, nothing. There's nothing except this aneurysm. And make a long story short, patient ended up in the ICU. I was about to take him to the operating room to repair the aneurysm. When I went back to the general surgeon, I said, I beg you, take a look at this patient again. This is not the clinical picture for an aneurysm. And I'm about to operate on this patient and make die on the table. Only then they went back to the radiologist. They found some evidence of very tiny air in the abdomen, which was missed because the radiologist was relying on AI. The general surgeon, the radiologist, everybody was just basically going with their interpretation. All it took was somebody to just put their hand on the patient's belly and said, this patient needs to go to the operating room immediately. Patient is struggling to stay alive right now. FDA needs to be more involved. That's my question. Is that going to happen or not?
All right. Europeans are setting guidelines and guardrails for AI in clinical medicine. In our country, that national committee was canceled. And it is a problem. Regarding FDA clearance, they don't approve, but they clear the AI tools, their devices. The bar is very low. For these AI support tools in mammography, they're approved based upon testing lab situations, not in real-world settings. That's a problem. They may be approved based upon a couple hundred mammograms, for example, the AI tools. Then you flip a switch, and companies can make money because 40 million mammograms are done each year. AI is really taking off. UCLA Health, we are using probably 70 to 100 different AI models currently. Nationally, there are AI docs that patients can contact and present their symptoms, and it will tell them, yes, you should see a doctor, or no, you can stay at home. State of Utah, AI bots are prescribing medications. So the guardrails are down right now.
I think we have time for one, maybe two more questions. We have a question right here in the center, right next. Yep, thank you.
Hi, thank you so much for your time. My name is Ellen. I have a very similar question, actually. So there's like a lot of gray area with automation, especially in geological areas where there are underserved populations. And I kind of wanted to know your individual speculation on how far automation will go before it impacts healthcare or it erodes clinician oversight.
I think this is a longer conversation, and I'll talk with you in the break. For example, a lot of the data in the medical records, it's stigmatizing, it's biased, and it's junk. I'm sorry, I'm a researcher too. One of our postdocs in the Clinical Scholars Program is studying the use of stigmatizing language to see whether, when I'm using my telephone AI ambient scribe, hopefully our verbal language with the patients that's being transcribed is better and less stigmatizing. And maybe the programs can even create red flags and get rid of some of the language that I was taught to use that is really inappropriate and unjust. So my hope is that it will help, but we need to be careful.
Okay, I think we have time for one more question. Did I see back in the corner over there? We could get a microphone.
Oh, okay. Hi, my name is Richard Lee. I'm a child psychiatrist at CHLA and USC. I'm a graduate here of the program. So We use AI quite a bit on the provider side and as well as in medical education. One of the things that I'm really interested in is how the general public is using AI, patient population is using AI, and how that's affecting clinical care and public health in general. I was wondering if you had any insights into how the general public is using AI for their clinical care. Thank you.
Well, I think there's a lot of dangers to it because, as we know, we all think we're experts in everything now because we can look it up, right? And so even before AI, that started with the internet, and I think it's 100 times worse now. So I think it's hard now because I'm not a clinician, but just talking to clinicians when patients come in, they already have their own diagnosis that clinicians have to sometimes fight them with. So I think there's that. On the psychiatry side, I think what's dangerous is people are replacing relationships with other humans with their AIs. You know, I was listening to a podcast where this guy has an AI wife I'm not joking, to go along with his real life wife, and he says, well, the AI likes whatever I like. And so that's so I mean, it's kind of crazy how this is going, but I think there are a lot of dangers in that area.
Great. Well, unfortunately, I think we're out of time now for our first panel, but please join me in thanking our expert panel. Professors Kamilata, Elmore, and Lee, thank you all so much. In the interest of time, it's now my pleasure to introduce my colleague, Professor Kristen Choi, who will moderate our next panel, Combating Chronic and Infectious Diseases. So, Dr. Choi.
Awesome. Thank you so much, Philip, and thanks to everyone for a great first panel. Our next panel on combating chronic and infectious disease, I think, is a perfect follow-up to this conversation on AI. I think all of us can see that even though there's some concerns and potential pitfalls with AI, there's also so much promise of these tools for improving public health and clinical care in some ways that are really exciting. But as we think about how the rubber meets the road, how do we really apply those tools to the most intractable public health problems? What we see is that 3 years, post ChatGPT first coming out, we still haven't solved disparities in cardiovascular disease or HIV or depression or other chronic diseases and infectious diseases that we know are impacting our communities. So I'm really excited for this discussion with 3 experts in chronic and infectious disease for us to talk about these problems, how they're affecting communities today, and for us to keep thinking about how we address them. So I'd like to start by welcoming up our first panelist, Dr. Susan Babby. Susan is a senior research scientist and co-director with the Chronic Disease Research Program at the UCLA Fielding School's Center for Health Policy Research. So welcome, Susan. Please come on up and tell us a bit about your work.
Okay. Thank you. Thank you, Kristen, and thank you, everyone. I'm really excited to be here. So as Kristen said, I am Sue Babby. I am Director of Research at the UCLA Center for Health Policy Research, and I also have an academic research appointment in the Department of Health Policy and Management. And I'm going to briefly talk about the importance of having access to data and of translating and disseminating evidence to help move from understanding chronic disease problems to informing policy solutions. So my work focuses on preventing chronic conditions by addressing the social, environmental, and structural conditions that shape health, particularly in populations that experience persistent inequities. These factors include food security, access to healthcare, neighborhood safety and green space, the food environment, and whether we even have disaggregated data to see who is affected. These factors impact both the size of the problem, so how many people are affected, but also inequities, who is disproportionately impacted. And importantly, these drivers are also places to intervene. They represent policy levers that can be changed or reimagined. At the Center for Health Policy Research, we conduct research with the goal of informing health policy. But you can't intervene effectively and make changes to practice, programs, and policy if you can't see the problem clearly. That requires relevant, high-quality data and research, because data can demonstrate that action is warranted, data can identify inequities, and data can identify the factors for policies to address or these places to intervene and make change. However, data alone aren't enough. Not only do we need to see the problem clearly, information needs to reach the people who can act on it. So there are many steps involved in getting from data to policy, but I want to highlight two that are central to our work. First, access to relevant and high-quality information, and also getting evidence into the hands of decision makers. So first, access to high-quality data. One of our projects at the center is the UCLA Data Equity Center, and the objective of the DEC, as we call it, is to promote data equity by helping data systems become more representative, inclusive, and collaborative with the communities they serve. So we work with organizations to include data equity in every step of the data lifecycle, from collection to dissemination, while involving relevant communities in each phase. And we are currently working with a cohort of state and local agencies who are forming a learning community with the objective of advancing policy and practice related to data equity. What we hope is that this work will help the agencies to make sure they have the data they need in the face of current threats to data systems, and so that inequities do not become invisible. So the second example shifts from having relevant high-quality data to transforming research findings so they can be used. This example is from a project we recently completed that examined the role of changes in eligibility for CalFresh, in access to the program, and in rates of food insecurity among college students in California. From this project, we produced fact sheets that were tailored for three audiences: policymakers, CalFresh and SNAP program administrators, and college campus programs that help connect students to CalFresh. And we also produced fact sheets with findings specific to each college that participated in this study. So finally, research shouldn't sit on a shelf. And you may have heard us say this before at CHPR. We like to say it. But at the end of this project, we conducted briefings in Sacramento to share our findings and recommendations with legislators, legislative staff, legislative committees, as well as staff in the Department of Social Services, which oversees and regulates CalFresh. And we did this to help get this information to those who could act on it. So when data are relevant and inclusive and shared in ways that are accessible, we hope that it can help drive decisions that can improve health and reduce inequities. Thank you.
Wonderful. Thank you so much, Dr. Babby. I'd like to invite up our next panelist, Dr. Rock Nyanogo. Dr. Nyanogo is an assistant professor in the Department of Epidemiology. Please join me in welcoming him up to continue our discussion.
Good morning. How are you guys doing? I'm very excited to be here today to talk to you about my research, at least what I've been thinking about since last night. But before I go on, I want to talk to you about my research group, who basically use countless hours to do all this work, so I can take all the credit for it. All right. In my lab, we try to use rigorous tools, machine learning, simulation modeling tools, as well as causal inference tool, to be able to understand the different lifestyle and metabolic and risk factors that help prevent chronic disease. Essentially, we try to understand what works, how it works, and for whom it works. But before we do that, let's talk about why we actually need to do that. 6 in 10 adults in the United States have chronic disease, and this is costing a lot of money, over $4 trillion million of dollars. I can't talk about all the chronic disease, but I'll talk about only 3 of them: heart disease, stroke, and diabetes. Heart disease has many risk factors, and the American Heart Association has identified many of them, like 8 risk factors that we can help prevent these heart disease. For example, losing weight, stopping smoking, and managing our diabetes. But if those do work, we should all be doing a lot of lifestyle interventions so that we can actually prevent our heart disease. There was this great study that was done a few years back to try to see if the lifestyle interventions could help prevent heart disease. And you guessed it, you found that unfortunately it failed to show an improvement in heart disease. So what does that mean? Should we all go home today and not exercise? I would say not yet. Because I was told I had only 7 minutes to talk to you about my research, I curated 25 studies to be able to talk to you about it. No, not just kidding, because I'm only going to be talking about 3 studies. The first one uses a simulation model to be able to understand if you were to be able to create a virtual reality. Remember, like the Matrix, instead of having to choose between the red and the blue pill, you're the one creating that virtual reality where you can actually investigate the potential impact of different interventions. You incorporate a lot of data sources and risk factors for different publicly available data set, and you can query as if you were to run a randomized control trial within a virtual system. What we found was interesting. As soon as you're able to implement an intervention all throughout an individual lifetime, especially focusing on fast food interventions as well as physical activity, this leads to a real decrease in obesity as well as diabetes. But it's in particular when you focus on physical activity as well as fast food consumption. So essentially, you need to be able to implement an intervention all throughout the individual lifetime, but also continuously. In the second study, we use causal inference to be able to look at different mechanisms and how basically very early signs of diabetes can help prevent heart disease. And here, we're just looking at one very early signs of diabetes, which is called insulin resistance. It's basically like, when you have like a high blood sugar and your pancreas secretes insulin to try to have your glucose get into your cells, and your cells are like, no more. This can lead to like more downstream effects that could later affect heart disease risk. So in this study with my students, we found that about 76% increased risk of heart disease among those who have very early signs of diabetes. But most importantly, about 50%, half of that association was actually mediated through metabolic syndrome, which is basically a constellation of risk factors, including high blood pressure, increased glucose. So it's very important to be able to understand not just what works, but also how it works. And in this study, we were able to understand that at least 50% of very early signs of diabetes could be mediated through like metabolic syndrome. But when we're talking about the disparities, there is greater opportunities to be able to stop the rise in heart disease among Black individuals if we were to be able to target these intermediate factors. And thirdly, we use machine learning to be able to understand, basically, you remember that study that I talked about in the beginning where they didn't find anything, to be able to see whom in that population actually were to be able to benefit most from that, from the intervention. In machine learning here, I'm using in the predictive sense. And, machine learning, what is that? You've all watched Netflix and maybe it proposed you like the next movie titles based on your profile, and you're like, how does that work? Yes. So we use that to be able to understand basically in your population, basically how many people are going to benefit from the intervention and how many are not going to benefit from it. Found something very cool, very interesting. At least one of the factors at baseline, the average blood glucose among individuals actually was able to like separate people into different categories. In the bottom left corner, you would see in the green over there, these were all the people, about 86% of that sample that benefited a little bit more from the intervention, while the other 14%, they did not. And actually, they even incurred harm. So here, the intensive lifestyle interventions, although initially we didn't find anything. I mean, I wasn't there, but we can look within the data to see actually who is actually among this population that could actually benefit more from this intervention. So the question is, the question should not be just does it work? It should be which combination of interventions works? How does it work? And for whom it works best? So just to tie it all together, if you want an intervention to work, do it all the time. And you do it only for the people for whom it's going to be beneficial. But if AI is any good at telling us something or being helpful, is that helping me create this graph? And unlike Dr. Lee, who didn't have any luck, I had a little bit more luck to be able to create this figure here. But in all seriousness, we should move a little bit away from one-size-fits-all interventions to more targeted, precise, personalized solutions for preventing heart disease, chronic disease, and this is what we call precision public health. Thank you.
Wonderful. Thank you so much, Dr. Nyanogo. I'd like to welcome up our final panelist for today, Dr. Jason Hsu. Dr. Hsu is an associate professor in the Department of Biostatistics, and he'll be rounding out our conversation before we open it up for Q&A. So welcome, Dr. Hsu.
All right, thank you. It's a pleasure to be here. Hey, everyone. And also, it's been a great panel discussion already. So some of the themes that we've already seen, we've seen there's so many sources of data, but data aren't quite enough. On the other hand, we see that we can't fully rely on the expertise of, whether it's physicians or maybe public health experts, even though a lot of what they do is amazing and isn't art. We also want to be aided by things, whether they're AI or whether they're models. And so we can't totally trust physicians. We can't totally trust AI. Unfortunately, my talk will be how we also can't totally trust models. But I think we've already set a really great stage for this conversation that I want to continue via my view. So there's a rich, I'm going to focus kind of narrowly, my view will focus kind of on the model of epidemics in terms of how a disease spreads through a population. For instance, doing the kinds of population modeling during COVID or an outbreak like that. And before I was a adult, I was a postdoc here in the Department of Biomathematics at UCLA. And I was exposed to the fact that there is really a rich tradition of mathematical modeling alongside epidemiology. And in that world, they know that we have some biological or epidemic knowledge on how a disease spreads, and we would like to make models that mechanistically reflect that knowledge, okay? So rather than, for instance, nowadays we have AI or any other kind of generic tool we might have like regression, rather than just applying a generic tool to study the kinds of data, maybe case counts or incidence or prevalence, we might want to actually model how we know that, well, there's who is infecting whom and what kind of interactions are happening. We might want to put that in our model to aid our analysis of the data. Okay? And so these models would like to account for population structure and contact rates. But what we want ideally in this talk is continuous time and random dynamics. So also after my postdoc and before joining our department, I was faculty in a statistics department at Duke. And so statisticians, of course, want to tell everyone that what they're doing is not quite right. I'm sure you've collaborated and had that experience. And so here too, I want to just say that, well, these mathematical models have really aided our understanding of disease spread, but also we need to question their outputs and kind of understand what is going on behind the machinery there. So what I'll focus our discussion on today is on the SIR, or Susceptible Infectious Removed Model. So many of you may have heard of this. It is one such population model that describes how an infection moves between groups of individuals in a population based on disease status. So here is sort of a classic figure of the SIR model. So you have susceptible individuals, infectious individuals, and recovered or removed individuals. And so these are the only equations here, I promise. I just want to mention that there are sort of a set of equations here that are textbook, and they can describe how these curves will evolve given some parameters. Here, it's a mechanistic model because it tries to at least capture the interaction between who's infected and who's susceptible. And parameters are also, in a mechanistic model, tend to be interpretable. So this is a very simple model, of course. There's an infection rate, which is beta, and a recovery rate gamma. Whereas, a neural network or some kind of machine learning model will have millions of parameters, and now with large language models, millions is tiny. And so, these things are a little simpler, a little more parsimonious, and hopefully they're more interpretable for us. The one thing I want to emphasize about this, rather than giving you a math lesson, is that given these parameters, the outputs or the trajectories of such a model are fixed, right? So if I had a particular number for beta and gamma, I get this set of curves. Of course, this is too simple, and we want to model more and more. What if vaccination matters? What if symptomatic versus not symptomatic matter? Or what if latency of the disease matter? So then all of a sudden, you're going to want to make more and more modeling assumptions and have a bigger diagram with more parameters to fit. And this can become complicated very quickly. So this is coming out of a group I really respect, Abel Gumel's group, who's moved to Maryland. And statistically, as we do more and more of this, the model is competing with explaining the data, right? We want these models to aid us in terms of the available data. But as we are making more assumptions and allowing that model to be more and more flexible, we also run the risk of overfitting. And this is a huge issue, especially because some of these observational studies, especially when in areas that aren't as, or when we're trying to integrate data across many countries, it might be sparse, and so we can't afford to make so many assumptions that we are overfitting the data. Not only that, many of these complicated models are only coming with a point estimate. So even though we've given it so many knobs and degrees of freedom, it's just going to tell us one answer, and we do not know whether to trust that answer. So the whole idea of this talk is just to motivate that we want a way to quantify this uncertainty, motivating maybe a stochastic or random modeling approach. So I've reintroduced this picture, and I just want to mention that if we had a random model instead, well, first of all, we see that there's maybe some variation in these curves, but the main difference is now, given a set of parameters, we can have multiple realizations of this curve. And I think that aligns more closely with how we understand the nature of epidemics, disease going through a population. There's a random aspect of that. There's a probability of an outbreak occurring at a certain date, things like this. So what we work on is to try to take this random or stochastic model perspective to do better than some of the mathematical literature while building upon it. So a lot of these models have simplifying assumptions behind them. In fact, even this one equation I showed you, the beta times S times I, that comes from if you assume that all the individuals in your population are connected at all times. And technically, if this graph had all the possible edges, then the number of edges between S and I individuals is S times I. Nowadays, we might have data informing us of a contact network via either a mobile health study or maybe just kind of apps such as that have Bluetooth data on your cell phones. We also might have other sources of data, such as phylogenetic data or some kind of spatial mobility data, where some of that side information can tell us about who infected whom. So these things can work together. On one hand, we have more data and more model, but that can allow us to relax some of the simplifying assumptions behind these classical models. On the other hand, as we want to account for more of these data, we do need to manage that balance. Like I mentioned, we don't want to overfit the data. We want to have selected the right model complexity for balancing the amount of data we have and avoid overfitting. And luckily, if we move into a statistical framework, there are formal and sort of principled model selection or variable selection criteria to allow us to do so in a principled way where we can not only trust what we're doing, but also understand the uncertainty behind each of our decisions. So this is finally a couple pictures from my work. Just as an example of these things in action, we looked at a previous analysis of phylogenetic summary data that would give us some information on who infected whom in a study. This is an HIV study. And we saw that before accounting for the uncertainty, they had to basically throw away pairs with low certainty. And in our method, which is a fully stochastic method, we can analyze the full data set, which gives us a different and maybe sort of smoother density surface for the age structure of transmission. So here we see these kinks might be due to throwing away enough data here that it's low density and overfitting those cases. On the right, I just have an example to illustrate that in the stochastic models, we have many realizations for one set of parameters. So we estimated the parameters in one of these simple models, and I'm showing the trajectories simulated from those parameters. But in orange is one of these methods that has been used and makes some simplifying assumptions. And in blue are the ones from the true stochastic process. And we see that we lose some of the variability, which sort of in more interpretable terms means that we would be overconfident in any kind of analysis or inference we draw from that model. And then this one down here is some work we've been working on where we try to correct that by adding that uncertainty back in a sense. And so again, the orange is the same thing here, but our correction is this green, which is not 100% equal to the true model still, because we're still fitting it to our data, but is doing a lot better capturing that variability so that as these models aid us in policy decisions or any other kind of actions or conclusions downstream, we're able to reason with that uncertainty and know how much to trust various aspects and outputs of such models. This is my last slide, keeping it kind of light. I didn't put any references or anything, but we are working on developing the tools to rigorously fit these disease models to the data we have. And importantly, we need to understand the associated uncertainty so that we can better make public health decisions based on the aid of these models and data. And again, I don't want to only criticize, what are the things that we're not doing perfectly in fitting models. Of course, some of these methods are statistically naive, but also I'm sure many epidemiologists and public health experts putting this into practice feel like the models we're using in statistics and mathematics are a little bit far from what people need, right? Our models are too simple or too naive. And so it is a two-way street. And I would love to work together to close this gap with the smart people in this room and outside of this room. So thank you so much.
Wonderful. Thank you so much. I want to invite Jason, Susan, and Rock to please come up for our moderated discussion with Q&A. And while you're all making your way up, I just want to thank you all again for your presentations. I think this has been a really interesting discussion of contemporary approaches that experts are using to think about chronic and infectious disease and how we do research in these areas, but also how we translate what we're finding into interventions as well as to policymakers. So thank you all very much. I'd like to open it up to the audience for questions. What questions do you have for our panelists today? And we'll have folks coming around with mics again as before. Yeah, here in the front. We've got a mic coming.
Really great talks. Thanks again. It got me thinking about a lot of possibilities. I'm going to throw something out there that's pretty far-reaching, but I just would love to hear your thoughts. People are starting to talk now about moving beyond traditional computing to quantum computers. And so that idea of beyond zeros and ones and bits to think of qubits where you have multiple states. And a lot of the talk is in genetics and protein folding and how that can take things that would take a regular computer maybe hundreds of years to do. We can reduce the time, but I haven't heard as much talk in the statistics realm and modeling. So I'm just curious if you have thoughts on would that be overkill? Is that even needed? Or if you've thought about this at all, how that could possibly help.
Thanks, Scott. Anyone want to take that one to start?
Yeah, that's a great question. So thank you, Scott, for the question. So yes, quantum computing, like you said, some fields are maybe embracing it already. I didn't realize it's being used in genetics already, and it has, of course, great promise in parallelizing some of the computations we care about and need. I would say it absolutely can. So the thing about quantum is I feel like quantum has been right around the corner to being usable for decades, but I think this time it does feel real. And I hit all the details in my talk, but in what we do, there's absolutely a lot of computation, a lot of simulation-based inference methods. That's the predominant way that we fit the stochastic versions of these models. So one thing I didn't say is, well, why do people not use stochastic models so much already? Frankly, it's because inference is computationally expensive. And so quantum could absolutely make a huge impact there if one can write the kinds of procedures we need, such as simulation, in a quantum-friendly way, right? So that's also an interesting problem in itself. I can speak to just that much in my modeling.
Thank you. What other questions do folks have for our panel? Yeah.
Oh. Hi, my name is Lilia Lukovsky. I am a graduate of School of Public Health here. I received my MPH and my PhD from Department of Epidemiology, and I currently work for the federal government. I'm a researcher, and I pretty much spent over a decade working as a researcher for within the federal government, and I've been working with federal databases, like the huge databases that contains millions of records, billions of entries, and all that. So I was listening to these presentations today, and specifically talking about how what is done here, at UCLA or other institutions, can be applied to the policies. And I would like to point out that the policies, we kind of assume that people who make policies, which are elected officials, they kind of come in with open mind, like we as researchers come in with open mind, but that's not the case. Depending on who are elected officials, the policy drastically change. The data, I've been working with the data for over a decade, federal data. It's the same data. The data hasn't changed. It's all the same. What changed is the policy. Whatever was the policy 2 years ago is drastically different from whatever it is now. So my question is, how do we reconcile that? How do we kind of keep in mind that people who are making the policy, they already come with preconceived notions based on their party affiliation, on their religious affiliation, their area where they're coming from, and they're not really interested in what we find, or whether the models were precise enough, or whether we tested it good, or whether we did whatever we had to do. They're just interested in finding data that is supporting their points of view, so they could kind of present it and say, this is why I'm right, and this is why we need this policy. This is why we have to, make abortion illegal, or this is why we have to do whatever. And this is all in the data. So how do we reconcile that? How do we kind of guide our research with these in mind, knowing that people who are making policies, they're not always going to be kind of open-minded and open-hearted, and they're just really looking for
this is
what they want to see.
Yeah, this is such a great question for our current moment. Maybe I can ask Susan to take this one first, and then would love to hear from the rest of the panel as well.
Sure. Yeah, I think I completely agree. This is a great question, particularly right now. I guess I have a couple of thoughts. One is it can be like, all right, what you said is true, and it can be very discouraging, but I think that means that we have to keep doing what we're doing, and because administrations change, policymakers change. It hasn't always been like this, and please, hopefully it won't always be like this. So that's my first thought. And then my second thought is, even when the majority of politicians or policymakers don't necessarily agree with or even want to hear what you may be trying to tell them, there are almost always going to be some policymakers who the issue is important to them. And I think, the place to start is with those policymakers. But also, and this is, I think, drawing a little bit more on my experience in the state, but I think you could also apply it nationally. If you can bring an issue to a policymaker that is heavily impacting their constituents, that can motivate them to do something about the issue. And it becomes even more powerful if you can get the constituents also involved, or some organizations, community organizations that are advocating on behalf of those constituents to bring the issue to the policymaker, to help them realize how important this issue is to their constituents, because they do ultimately have to answer to their constituents, because the constituents can vote them out.
I just want to add to that as well to say that we can only do what we can do in terms of like researchers, and overpowering them with more good quality research. That's the first thing that we need to do. The second thing that I think we need to also learn is to learn how to communicate, because I think unfortunately as scientists, we all work in a siloed, and we only talk to our collaborators, but not to the community, and maybe they would not have enough to be able to say to politicians and things like that. So I think we have to learn how to communicate our research findings, do good quality research.
Yeah, I don't have too much to add. This question is a little bit beyond my pay grade. I'll just say, I also think naturally in just terms of, well, how can you, other than just having a better study and research, but part of the question is about, well, how does that get through to people between the research they are cherry picking and maybe the constituents of the audience? And I guess we haven't talked a lot about education in our panel, but whether it's a solution or whether it's my own personal way of coping, I think just having a strong, education of the public and having people be scientifically literate and statistically literate, it's my bias, and just being able to evaluate research and what people are saying is one way we can hope to change that.
Great, thanks, Jason. Everyone, I'm glad we have a panel that covers everything from quantum computing to policy. It's excellent. Any other questions? Yeah.
Got it, Brad. Sure. Jack Needleman, professor in the Department of Health Policy and Management. There's been a lot of discussion of heterogeneity of risk in epidemic and in terms of infectious disease and who's at risk of being infected, heterogeneity in terms of who it benefits from given programs. But we've also heard a lot of risks of heterogeneity. Joan Elmore spoke about an algorithm that confused spending, which was influenced by lack of access to care, as being health. Machine learning algorithms are notorious for aggressively partitioning their data. And I'm just wondering, as you look for heterogeneity, differences across subpopulations within your data, what you do in your research to make sure that you're capturing accurate and informative variation in either risk or performance, as opposed to artifacts from the data that simply are not true representations of variations due to heterogeneity.
Thanks for that, Jack. Yeah, Brock, do you want to start us off?
Yes, thank you so much for the question. And actually, I completely agree with you as well. And I'm also very skeptical of machine learning tools. That's why, like in my lab, for example, I'm a big proponent of explainable machine learning tools, like those that at least at face value we can all understand. And actually, the last study that we talked about, we started off doing this study to compare like something that is more transparent to like a machine learning that is more like black boxy. And in doing so, we found, what I presented today, which is something that people have also done in the past. So I think first, we need to use tools that are very transparent, that people can, evaluate and be sure to, validate it with different data sets. I think that's also very important because sometimes if we only focus on just one data set, it may give you an answer that's not generalizable to like other data sets. So I would say be careful about how, quote unquote, train the model, but use things that are more explainable, more transparent, and that could help us at least to make better decision making because we know exactly what went into the model, basically.
Thank you. Any other thoughts from panelists on that question? Just kind of how we address heterogeneity?
Yeah, I'll add to it a little bit. I think it's a great question, and I think it's one of the most important things we think about. And part of what I mentioned in the talk is, from a statistical perspective, that's something so classic, like what is signal and what is noise, and how many variables can I afford to put in before they're competing for explanation, right? And in the most canonical tools we use, like regression, it's always do I include an additional variable and beta, or when do I stop? And so there are many ways that, many methods we have to think about this, but in the sort of the modern age, there's also a lot of impressive tools that don't come with those safeguards or with those selection strategies. And so part of, I think, a good idea is to sort of know which regime you're operating in and be skeptical if something doesn't give you access to these kinds of selection things. But otherwise, also maybe using some more classical machinery too to double check your solutions where they have formal criteria for selecting those things, if that helps.
Thank you. We do have time for some more questions. Any other questions from the audience? Yeah, here in the front.
I was wondering when it came to models of pandemics, modeling them as stochastic flows over networks sounds great, but then there's also this component where human behavior changes in response to pandemic conditions. So I was wondering if there was a lot of active work in this area, if there was a lot of progress since, say, 2020, when I know there was a little bit of a surge in research. So yeah, modeling human behavior.
I guess that one's a little bit directed at my talk. So this is a great question. And there was, in fact, the NSF had a big push on grants that really had social scientists and people in human behavioral fields working together with the modelers. I've done a little bit of that myself. And so it's just such a nebulous and broad problem. And part of that, one of the things I've modeled is like, well, does your social contact influence your disease risk profile and vice versa, right? So if you're sick, are you going to interact less, et cetera? And so it's interesting because in our findings, it was kind of just what you would expect. Like if you're quarantining yourself, you're going to have less risk. I also have economist colleagues who found that, well, some people, it's the opposite, yeah, right? So some people, if they know they already have the disease, then they might as well go out. And so it's a really rich field in terms of how you are studying human behavior, and I think it's a necessary one to work at. So certainly the economist is one, economics is one field where they're looking at that in terms of game theoretic equilibria and those kinds of models. I'm sure there are more that I'm unaware of, but indeed, right around 2020, there was a big push for that.
Maybe what I'll add to that is that I know different simulation models can help answer different questions, and I think we should certainly try to move towards simulation models that incorporate heterogeneity, like basically, how different individuals react to different things, but also like incorporating our knowledge about human behavior. And, we can use a lot of the research that can guide us in basically be able to inform the model. So I think a more informed model will help us to make better prediction. That's what I would add here.
Great, thank you. I think we have another question down here in the front.
Hi, this is a question for Dr. Babby. So I know we just talked about how do we get the information, how do we make sure that people that can make changes actually care about the information we get, but how do you feel about kind of the field of gathering that information? I know a lot of the work that you do at the Center for Health Policy Research is survey work and getting, the making sure all the people are included, but what is the kind of your perception of how the field is moving and how we have to be creative so people will give us, their opinions and the other things we need to act on?
Yeah, thanks for that question, Beth. I have a couple of thoughts on that. I think, in general, using survey data is challenging because collecting the data is challenging. Getting a representative sample is very hard, and it's getting more difficult, not less, because people are increasingly unwilling to spend the time. They're increasingly, and not wrongly so, distrusting. And I think particularly in the current moment, there are also significant concerns about how the information can be used and whether it can be adequately protected, as people were promised before they participated in these kinds of studies. So I think this is a very challenging time for this kind of data collection, but we also really rely heavily on it to understand the scope of the problem, both at the state level, also nationally. And without that information, we don't really have a good picture of where are we? Are things getting better? Are things getting worse? If things are getting better, are they getting better for everyone or only for some people? So I guess I would say that I'm concerned, definitely, but also encouraged, partially because I work at the center where we have the California Health Interview Survey, and I know those folks have been working incredibly hard to address many of these challenges, doing a lot of interesting and innovative things that I'm not really the best person to speak about, but it does give me hope that we can figure out how to continue to have this information that we need.
Thank you. Rock and Jason, any thoughts on that question, just about kind of the issue of data and how we approach data gathering in the work you're doing?
Yeah, thanks for putting me on the spot. But but yeah, I think especially when it comes to like analyzing data and making predictions and getting a causal estimate, it's important to be able to find good data. And I think unfortunately, like as we all seen, like this year, a lot of the past couple of years, like some of the data were no longer accessible, and that's also a problem. And if we want to be able to build good models, to be able to like have good inferences, we need to be able to have these data. And I don't know what the solution is in terms of like being able to like have encourage like the population to be able to answer more questions and surveys and all that. But I think we have to like embrace the times. I don't know if it needs to be more virtual or more compensated, but we have to be able to think about ways to increase data collection so that we can inform better our models, so that we can also inform policy decision makers.
Great, thank you. Any other questions from the audience? We have time for maybe one or two more. Yeah.
Hi, my name is Julian. I'm the Senior Assistant Dean for Student Services. The first two panels got me really thinking about, data and how to implement it. I think just to kind of leave us on a good note or positive note, is there anything positive or productive that you've been seeing as of late in terms of the data, research, and how it's influenced any actions or policies as of late? Just to kind of leave us with some hope.
Yeah, thank you very much for that question. I think I'm very hopeful that with a lot of the work that we've been doing, especially as researchers here, it will be used to inform policy decision making, but also clinical settings. So, for example, imagine I mentioned the study on the look ahead. Imagine before you would say, just exercise or try to lose weight. It's very general, very broad, to everyone and all that. But if we're like a little bit honest in terms of being able to carefully read the data and what it tells us in terms of what can work. For example, you would say if you're early in, let's say, the diabetes process, this will work or might work. But if you're a little bit later in the process, it might not work. And actually, that's a very empowering message, as opposed to like telling someone, just try it and it doesn't work, and then they become disenchanted with the whole health system. So I think it's a great moment that we have now, that we can try to do more personalized and precision, public health, to be able to target communities with what they need and giving like very clear strategies for preventing disease. So I'm very hopeful for that.
Great, thank you.
And I think I would just add that what I find encouraging is actually all of you being here, all of these smart, hardworking people that are concerned about the public's health and how we are continuing to try and do this work during what can be challenging times.
Great. Well, I want to give a big thank you to all of our panelists. This was a really excellent discussion, and I really appreciate all of your comments. And I think it's, again, gone really nicely with the previous panel, too, talking about AI and how we use the many new tools that are out there to approach public health. So thank you all very much. I'd like to invite Dr. Masenko back up to move us into our break. Come on up.
Thank you to our moderators and two really thought-provoking panels. Thank you. I think we're going to be talking about the material that you discussed in our break. So now we do have 10 minutes built into our schedule. After that, Dr. Erica Pan is here and will deliver her keynote address at 11 o'clock. See you in a bit.
Welcome back. Thank you so much for being here and joining this morning session. And I'm very delighted to introduce our keynote speaker, Dr. Erica Pan. Dr. Pan is the Director and State Public Health Officer for the California Department of Public Health, a role that she has held since February of 2025. Prior to Dr. Pan's current leadership role, she served as Acting State Public Health Officer at the California Department of Public Health and was the department's Deputy Director at the Center for Infectious Diseases and State Epidemiologist for about 5 years. As Director and State Public Health Officer, Dr. Pan is at the forefront of shaping and implementing public health for our state and building collaborative partnerships to communicate the importance and the power of public health, all to make our communities healthier. I'm extremely grateful to Dr. Pan for making the trip to being with us today. Thank you so much. Please join me in welcoming Dr. Erica Pan.
Wonderful. Good morning. Thank you so much, Ron. And it's really a pleasure and an honor to be here. So you've heard a little bit about my background, but I thought I would tell you today a little bit about my journey. I think when I was in student sort of seats and shoes, I was always curious about, what were different people's ways? How did you get to where you are? And, what were some things along the way? So I'll talk a little bit about that. And certainly that just leads into sort of the very difficult and challenging time we have in public health right now and what we're doing in California to respond. And it all really resonates with the theme of your day as far as research and innovation and impact. So I'm really excited to share some of the things that are evolving here in California, despite a lot of the challenges we have in public health. So with that, and I think, a lot of the way I've been thinking about public health and my job and my work lately are how do we meet the moment? So look forward to talking more about this. So just to tell you a little bit more, you heard, sort of the, I think just stepping back even to my undergrad shoes, because it sounds like there's some undergrads here too, and just thinking, I was sort of a reluctant pre-med and I really loved the sciences. I really loved the idea of direct clinical service or being able to take care of people directly. But I also started to be curious, even in undergrad, about health policy and having that broader impact too. And even then, I think it's sort of sad to me to reflect, but I remember a really impactful human biology course talking about how we really needed universal healthcare coverage in this country and how important that would be and how challenging it would be in this country. And that sort of sparked my interest, but then I think I shifted gears a little bit to think more about public health versus that sort of whole field of health coverage. And so I actually applied to joint MD-MPH programs. So Tufts had, at the time, now they finally have a freestanding program, but MPH program, but they had one of the few in the country that had a joint MD-MPH program. So I applied and went there, and that's where I did my medical school and kind of fit in my MPH classes, with my clinical classwork the first 2 years. And then during our clinical rotations, we had a set time when the few of us doing both did that. And again, now they have some actual school of public health that's independent of the joint programs. And then I came back to the West Coast and did my pediatric residency at UCSF. And I've been in the Bay Area ever since. And I think as I was thinking about pediatrics and just exploring again, what do I want to do with my sort of joint degrees? I do want to have that broader impact. And I thought a lot about, I wanted to have a little bit of a niche within general pediatrics, but still broad enough. And I wanted it to have a public health sort of overlap. So infectious diseases was a really natural thing to do. And I spent more time doing a fellowship in infectious diseases. And then had a lot of thought then too, like, do I want to do research and do kind of public health research or stay in academics? Do I want to do more sort of practical public health, like in the field, and ended up in San Francisco, staying in San Francisco and doing another kind of trainee time. A mentor at the time who hired me to do that set it up a little bit like the EIS program, but she was a former EIS fellow and tried to, one of my first roles was to investigate an E. coli outbreak in a nursing facility, a skilled nursing facility. And it was shorter and certainly didn't have the kind of colleagues that you have at the CDC EIS program, but it was a great experience there too. And then I stayed on in San Francisco and did a lot of different jobs. It's sort of interesting around that time, a couple of years post 9/11, there was a lot of bioterrorism funding. We had a big smallpox vaccination effort happening in 2003. So there was a lot of effort there, a lot of urban, like there was Homeland Security money. That's right after Homeland Security was created. So there was a lot of public health funding that was going to infectious disease emergencies and public health emergencies, which if you'd asked me then, is that what my interest or passion would be? I probably actually then would have said vaccines, but it was just sort of where a lot of the resources and jobs were. So I had a job in San Francisco, very ironic given what I've now been through, but leading a team focusing on infectious disease emergencies. And then around 2005 was when the first sort of H5N1 scare of, this is going to be our next pandemic. And that we were seeing a lot of bird flu and H5N1 in Asia. Thankfully, that never became human-to-human transmission and still hasn't, but but there was a lot more resources for pandemic flu planning then too, and also developed a real network within the Bay Area across the health officers in San Francisco. And then moved to Alameda County, which is in the East Bay, and I actually live in Oakland, and moved over there to do a broader job that did all of communicable disease control and prevention. And it was a perfect fit for me because it was emergency preparedness also, including our labs. I was closer to home, which was nice. So I served in Alameda County for several years. That's where I had more interactions with my namesake. There's no relation to Dr. Richard Pan, for those of you that know of him or know him, but everyone always asks. And I'm a huge fan and got to testify a couple times, actually, as a local health official for some of his really important bills, strengthening vaccine policies in California. So that was also when I got a taste of, really interested in statewide policy too and input. And then interestingly, actually, do many of you know who your local health officer here is in LA County? Dr. Ferrer is the director, and then the health officer is Dr. Mantu Davis. So he was the health officer in Alameda County and had hired me. When he came down here, I became the acting Alameda County health officer, and so was doing that for actually almost 2 years when the pandemic hit. And then you can see a sort of life-changing moment for all of us, actually. When the pandemic hit in March 2020, I was one of 7 health officers in the Bay Area that issued that first stay-at-home order in the country, actually. And it's so interesting because I think that was one of the hardest decisions, of course, any of us had ever made. But what was even harder, which, is a whole other talk that we're not talking about today, but is how do you reopen? Like, we knew it was the right decision then to shut, have people stay at home. And we knew all the outcomes from 1918 were much better in places that did that faster and sooner. But there wasn't a lot of information about how you reopen. But anyway, that was a really kind of important day, March 16th, 2020. And interesting, one of the other sort of doctors in a white coat there is Dr. Tomas Aragon, who was the San Francisco health officer at the time, who I'd also worked with in San Francisco. And he later joined. So in July 2020, I joined the state in the middle of, quiet time. Pandemic, we're having another surge. We were trying to reopen. And that's my swearing in with Dr. Sonia Angel. And it was interesting then, we had to be 6 feet apart. We were wearing masks. None of my family could come. No one could do anything, actually, at that time. So the only other person in the room was the photographer. But I was sworn in and then whisked off to our emergency operations center outside of Sacramento and worked nonstop on pandemic work for all of that time. But that had been really a dream job for me, to be the state epidemiologist and overseeing infectious diseases, because that's my background. And I had been excited about that potential position. I knew that my predecessor was retiring in 2019, but it took until and in the middle of the pandemic for them to actually recruit and hire the position. So I sort of dove in the middle of all that. And then Dr. Aragon joined us in 2021 and became the state health officer and director, which I was incredibly grateful for. We had already worked together. It was really nice to have another colleague working, closely together. And then he just retired last January. So I was asked to sort of fill his big shoes. And so I've been doing this for a little bit over a year as the director and state health officer. And then this other picture is me with Secretary Johnson during my swearing in as the health officer. And it was a really nice and different experience because we could stand together. And my husband and my daughter could come, and my older daughter was virtual from afar. And our whole team from CDPH was able to come in person. It was just a completely different, great experience. But that's just a little bit about my journey. And of course, along all that way, as we all know, right, in the last 5 or 6 years post-pandemic, or living through the pandemic in public health, and then MPOX, none of us have really had time to recover. So, feeling really exhausted. Actually, ironically, the other thing I didn't say, but I had been able to see patients when I was in Alameda County, but I hadn't really ever gotten back to that at the state, and really kept thinking, okay, I'm going to try to figure out how to get back to doing that. And then Dr. Aragon retired. So none of us have recovered, and then, jumped into a whole new world in 2025 in public health. And when people asked me early last year, how is your job? How is it going? The way I've been describing it is, it feels like trying to be the captain of a ship where you're going into uncharted, stormy, turbulent waters, unpredictable, and they're attacking the hull. But the most important thing, and one of the reasons I'm here today too, to talk to all of you, is that we have an incredible crew. The public health community, I know at CDPH we have an incredible team, and the local health department community, the academic public health community, and just the public health world. It's always been, it's been always a perfect fit for me, and we just have such a dedicated, passionate team. And I know we will get through to the other side because we have an amazing crew. So, just saying more concretely about what those stormy waters and turbulence look like. I mean, you all know this, but I think we've just seen a lot of impacts to public health in the past year and some months. Organizationally, there's been huge reductions in force, and then, people getting fired and then rehired. Then there's just attrition because people, don't feel like they have job certainty or other things. And then, of course, science is being attacked. There's a lot of unsupported claims out there that we are all trying to, work towards getting good information to people, which is something I'm going to talk more about. And then, of course, data, which is what, so much of you are here today probably working on and presenting. Data has been compromised in everything from security to taking data down to stopping looking at disaggregate data of the populations that we really need to serve the most. And that leads me to community safety and belonging has been a threat. So not only for our own teams of the people we work with, but certainly the people we serve. It's been a really hard year for all of us. And I think the other thing I'd just like to emphasize in many different stages is that when people hear about, that initial presidential budget last year proposed cutting the CDC basically by half as far as the funding, 80% of the funding at the CDC goes to state and local health departments. So if you're cutting that, you are cutting state and local health departments. And then I would just sort of let you know, then at the state level, almost half of our funding is federal. And we're actually lucky. There are many other states that are 50 to 80, like the range that our state health officials organization cites is 50 to 80% of their budgets in other state health departments are federal funding. And then kind of in turn of our overall CDPH budget, about 2/3 of that typically will go to local health departments, the 61 local health departments in California, and of course some other community-based partners or other locals. We have had all kinds of grant proposed terminations. Thankfully, we've had a lot of legal ability to push back on those and injunctions on those, grant delays, restrictions. Just this week, we've had some new concerns about, relooking at work plans because they're not aligned with the current CDC priorities. It's just been, a roller coaster of what funding will we have or not. The presidential budget looked completely different than what Congress finally ultimately was able to pass. And then the new presidential budget looks pretty similar, but then we just really have no idea what will actually happen when it gets to the legislature. So it has been, again, a lot of uncertainty and a lot of challenges. And then in the state too, we have a huge, even independent of the federal cuts to things like Medicaid and Medicare. We did have a huge cut to our nutrition and physical activity branch from the HR 1 budget last year, but we also have a state budget deficit to wrangle as well. And it's not like public health was flush to begin with. So one of the first things, we had just actually finalized, Dr. Aragon had just unveiled a 2025 to 2030 strategic plan. But one of the first things I started to do, and we have done as a team over the last year, is step back and say, we need to refresh this because we have to reimagine public health. We really, again, have to meet this moment. This is a critical, unique time. And what does that mean? What are ways we can reimagine public health? So one, of course, really important thing, anytime you have potential cuts, you have to prioritize. So we have to really, we've asked our teams to really think about what are the most impactful efforts that they do, what is unique to our role as a state public health department. We are still keeping equity first and foremost as an underlying principle. And then we do have to think about cost effectiveness, which we don't learn enough about in public health or other trainings, I think, but it is really critical. So prioritizing across the department, thinking about our core functions, some distinctions about what, again, is unique in a public health governmental role versus, working with partners like yourselves in academics or other private sector in the healthcare system. And then optimizing our resources for maximal impact. So a lot of that is just improving any efficiencies within our department and within our teams, but also strengthening partnerships and collaboration. And I'm going to talk more about that and a lot about, again, what it sounds like you're all here today to do. And along with your theme as well, innovating. We need to continue to embrace technology and data modernization and innovate and think differently about both how we can embrace technology to help us do our work better and innovate in the way we're actually funded, because this boom and bust is, it's been our whole history. And the one thing I always thought might change that is a huge once-in-a-century pandemic of the scope that we just had, and it actually did the opposite. It actually cut our resources further. So we need to think about it differently, and that's what we've been starting to do in California. So how do we rise out of the ashes? We unveiled in December a public health network information exchange initiative, and I'm going to talk a lot about the 3 pillars of that and the way we're thinking about this, but really honored, many of you saw what happened, and now we're going to see what happens in this current cycle, but there was briefly a CDC director, Dr. Susan Collar-Menares. She was Senate confirmed. She was in the position for 29 days. And then because she wanted to uphold science, she was fired. And their loss is our gain. We were able to bring her on to help work with us and advise us. She's helping us work on innovation. Dr. Deb Howry was the CDC Chief Medical Officer, Deputy Director, also resigned from the CDC in protest when Dr. Menares was fired. We were able to bring her on as well to help us in our collaboration. And then how many of you follow or know of Dr. Caitlin Jetelina, your local epi? A few. Okay, well, I hope to sell you a little bit more on her too, and we're partnering with her on communication. Oh, and anyway, one other quick fun tidbit, just as far as the fun sort of pictures I've thrown in here. So we were doing a press conference on this in December, and a couple fun things. This was like right before we were about to this is like the practice kind of virtual green room with the governor and Secretary Johnson and the rest of us. And he was marveling on a couple of things. He was he was just in awe. He's like, wow, look at all these women leaders all together. All of you are a powerhouse. And then the first partner posted some different things about this that day, saying women rule. And I just, was really embracing that. And then the reason we're smiling and laughing here is he's been really excited about this initiative too. And he said, I have never seen Dr. Pons smile this much. He's like, I guess that's because we've always been just talking about COVID and bird flu. And, I'm like usually so stressed. And this was like an opportunity to do something about the crisis at hand. So what is Phoenix and what are the pillars? So again, innovation, collaboration, and communication. So I'm going to go through each of these. So as far as collaboration and strengthening partnerships, we in California have really been stepping up in a lot of different ways. There's certainly at the national level, we're part of a larger Governor's Public Health Alliance, which is 15 states that span across, the geography of the country. It is intended to be nonpartisan, although currently it is all blue states. So we're part of that. And then we joined the World Health Organization Global Outbreak Alert Response Network, actually last September. It didn't get a lot of sort of coverage until the other convening that I'm blanking on right now. Anyway, so we did that actually last September, and we've been on these weekly calls to hear, along with other countries and other organizations, about what's happening kind of for situational awareness. Currently, the CDC has still been on those calls, but we've been very worried about the World Health Organization withdrawal and wanting to have some early situational awareness and trying to figure out how can we best continue to be aware, being such a large international global place like California, and knowing that diseases don't have borders. So that's been great work that we're continuing to. We got to present about our experience with H5N1 during those recent events. And I'm going to spend a little bit more time on some of the regional work. So the West Coast Health Alliance, again, I know there's a lot of questions about this. It's Hawaii, Washington, Oregon, and California. And our scope is essentially, responding to health threats related to national public health policy recommendations. And that's really a large focus initially. We've been focusing on immunization recommendations, but we have our eye on other preventive services guidelines. And certainly in the last week or two, it really sounds like that is becoming more of a threat as well. Also keeping an eye on things like infection control prevention guidance. There's many of those committees have not met or have been dismantled, including HICPAC, which does infection control, and also sort of just keeping our eye on FDA authorization changes, which is sort of related to vaccine recommendations as a start. So we as a team, this is really both it's governors led too, as far as the governor's offices and health leads there, but then we meet weekly with my counterparts in these other 4 states. And then depending on what topics we're talking about, a lot of our immunization subject matter experts from within our departments are joining us to look at, well, what is the AAP saying now? What is AAFP saying now about vaccine schedules, and who are we going to endorse? And how can we align on these things if we think these are based on credible, sound evidence? And then, of course, then developing some unified health policy statements and recommendations that can be implemented in each state as it needs to be. And then a huge theme over and over again is communications, and really addressing, again, just sort of unfounded claims and rumors and other information that are circulating. So the RWJ Foundation has actually also given us $1 million to support and work with the Public Health Institute and support not only the 4 West Coast Health Alliance states, but also the health departments we've invited, at least at the end of March, we just had a meeting in San Francisco where we were able to invite 10 other states in our region on the West Coast to really, again, think about what does our public health ecosystem look like? How can we be stronger together? And how can we, lead together and meet the moment? So we had a panel thinking about collaboration. Former Governor Levitt, I meant to double check. I think he was in Utah before, has done a lot of collaborations, and he gave us some lessons learned, and just really had some great thought partnership around some key areas. There were interviews of the different states before this, and some themes that came through we wanted to work on were thinking about infection sort of prevention and vaccines, data sharing, and emergency preparedness and communications. So again, you'll see some similar themes throughout this, but it was a really great convening. We had the dream team was there again too in person, really talking about these different aspects, and more to come on that too. There our partners at IDEO who helped work on this and help facilitate are going to do a synthesis, and we're going to think about what are some next steps as a region that we want to follow up on. And then I just wanted to highlight again something we can be really proud of here in California. So AB 144 was passed last fall in partnership with the legislature to really establish with all these concerns about what happened with the Advisory Committee on Immunization Practices and the loss of the usual processes of vetting not only the members of the committee, but how they actually look at data and evidence and look at evidence to recommendations and weighing benefits and risks. We were, again, very concerned about what was happening with those recommendations. So we worked with the legislature. This is another one of these full court press efforts to get this, done right at the end of the legislative session. Thanks. And pass a law that says that we are no longer going to, point to ACIP. We're going to allow the California Department of Public Health to look at other professional medical organizations and make recommendations. And this is something that all health insurance plans will need to follow. It also addressed scope of practice for pharmacists and other allied professionals, what they can vaccine against, and even had some liability protections too. And is a very comprehensive law that, and it will also hold U.S. Preventive Services Task Force recommendations through January 1st, 2025, and longer if needed. And then if there's new recommendations, we'll update them. So where do you find the latest information on that? It's on our Public Health for All website. And this is where we'll be continuing to update. So we have, we point to the AAP schedule for pediatrics, et cetera, is all on that website. And then I want to briefly mention to the FACT Coalition, Public Health for All Californians Together. So this is a really great state-based thing. It's modeled after the Common Health Coalition, and we've been partnering with UCSF in Northern California and covered California as public purchasers. And our organization with them have brought together groups from all over, all these different sectors to really, again, continue to build trust and strengthen and clarify recommendations. We have 3 work groups that are based on communications, community partnerships, and then data to implementation, starting with vaccines as a focus and vaccine confidence and access. So that's something. And here's a QR code if you want to join. We have over 1,300 people, and I think it's over 300 organizations so far. We do have many of the schools of public health have been, tuning in and participating, and some in the work groups as well. As far as communication, just quickly touching on this too. So again, Dr. Caitlin Gentilino, we are a launch partner for something we're calling Project Stethoscope. We are really improving and thinking about how do we listen to our communities better, and how do we leverage, for example, social media monitoring. Traditionally, public health would just do one direction communication through traditional media outlets, like what's the local newspaper, what are the local TV channels. That is not how people get their information anymore. And with these other tools in social media monitoring, you can kind of hear what the chatter is. What is the response when we post XYZ and this recommendation, and what other questions do people have? So really, working with them to have sort of expert-informed, behavioral specialist-informed social media monitoring to help us think more about what are the messages we need to get out there, how are they landing, what are the ongoing questions people have, or how are they maybe did they believe something different than what we intended? All of that. And then doing targeted outreach through surveys, focus groups, and other engagement. So it's both online media monitoring, but also partnering with others to do some focus groups. And then they're helping us develop tools that we're sharing with all the local health departments, with the FACT Coalition, to really help us communicate better and think about the diverse types of communities we need to reach and how to customize communications to different communities. And on that note, really building a community messenger network, because again, we know in a diverse state like this, and certainly in a diverse country, that everyone wants and needs different information, and they might need to hear or see it differently. So trying to really try to customize and build a network of networks. And then finally, innovation, just to get to kind of your theme today. This one is the earliest stages. We're still kind of trying to work in progress on this, but we want to foster an innovation institute that can bring together academia, the state, public health, and health and human services, the private sector, really importantly, because that's where a lot of the resources are, and philanthropy, to help us really think more about how can we build better data infrastructure, better sustainability, and really leverage all this technology that is accelerating exponentially around us. And usually in public health, we get left behind. So we're working right now to try to find a host institute, try to bring together a governing structure for this, and see if we can get some private sector investments as well. And what we can offer in California in public health is to be test beds. And if you can do it in California, you can then do that in a lot of different places. So with that, again, data infrastructure, technology, and funding infrastructure are kind of the areas that we want to work on. We really want to focus early on healthcare data interoperability with public health. We have so many different feeds, so many different clunky ways we're doing that right now. And how do we leverage the current technology to do that if we can actually get the right resources and people together? And with that, we did a convening earlier this year with some thought partners across these different sectors. And this is some of our team as well within the department. Dr. Larry Brilliant, some of you may know or have heard of, was there and has been a big champion. So more to come on this. We're really excited about this initiative, and we're hoping to move forward on this very soon, but still kind of in early stages. But I think it's the perfect kind of organization that UCLA Innovation and others can work together to be a part of. And with that, I just want to say one quote here. Winston Churchill is actually the person, we've been saying this a lot, unfortunately, in the last year and a half, never let a good crisis go to waste. And I didn't know where that really came from. And actually, Winston Churchill is the person that's been credited to say that. And he also is known for saying, the pessimist sees difficulty in every opportunity, and optimist sees the opportunity in every difficulty. And, we're holding on to that. And I think how that mindset can really shape your reality. And if they're going to dismantle our hull, we're going to come at the other end with a hovercraft. So with the right team and the right crew. And with that, just some acknowledgments. And that is the end of my talk. Thank you.
Well, that was terrific. Thank you so much. We're going to take some questions. I'm going to start off and lead with a couple of questions, and then please gather your questions. So I'd like to start with misinformation and disinformation. And I obviously have a lot of effort to try to get the information out. But where are we in California with vaccine hesitancy? Especially with measles and mpox now. What's the current status? Are you concerned? And how do we begin to engage and talk with family or friends or communities who are very confused and just don't know what to do? How do we approach it?
Yeah, there's a lot in that question. But yeah, I think as far as, am I concerned? So on one hand, really, again, even that in that early slide, we have some really strong laws in California that are being contested. But to really, especially in school settings and daycare settings, to have strong vaccine requirements. So overall, as a state, we have high vaccination levels. And like other places, we have pockets of unvaccinated communities. And that is where we are and are seeing some outbreaks. So we already have over 40 cases of measles in California, just as of this week. That is, we only had 25 in the entire year last year. And the last time, we're on target now. I was just looking at this, and during the Disneyland measles outbreak, which some of you may or may not remember, in 2015, we had 130 cases. And that was like the most we'd had in decades since the elimination of measles in 2000. So I'm very worried. We are seeing some pockets of unvaccinated people. Most of those cases were introduced from traveling either to other countries or other areas of the country where there are larger outbreaks in unvaccinated communities. Over 95% of those cases are unvaccinated. So we are worried. I'm worried the World Cup is coming. It's going to be coming here to LA and to Northern California. Summer travel, we are going to see more measles. It is such an infectious disease, and vaccines are the answer. So as far as, even it's interesting, even the words misinformation are apparently starting to be, are not landing well with certain communities. So we're trying to say things like unsupported claims or rumors or, misfounded sort of, anyway, so learning from, I think as far as an academic setting too, really working more with your behavioral and communication specialists. And what we're trying to do with your local epidemiologist is get more of those tools. Another example they've helped us with in some of the very religious communities, that it wasn't even that their religion was the reason they were unvaccinated, but just a lot of lack of vaccine confidence, but coming up with some messaging that really, points to, if it's a Christian community, pointing to some ethics and or values in those communities that can really resonate related to vaccines. And so there's sort of a toolkit that your local epi has shared with us in Sacramento and Placer County right now is a larger outbreak that's happening. So we're trying to again, listen more and hear and understand, what are people hearing, and what will help them understand better, and what information do they need to know about, what will make them feel more comfortable about vaccinating. So I think there's a lot of work to do, and again, different communities are going to need different things. So that's where really making this network of networks is also, I think, what's really important.
I was taken with your last couple of slides. I think you had Winston Churchill, and every challenge, there's an opportunity. And we have a number of students here who maybe and faculty probably, who are questioning public health and was this the right career choice? Because there are a lot of obstacles here, and funding is an obstacle. And what advice do you give for our students and our faculty who are wondering about careers in public health, and we need a public health workforce? How do we address that? And what guidance would you give for students who are considering public health or already in public health school?
Yeah, I think that's why I'm here, actually, because I am worried about our public health workforce, and I really want to, and I'm inspired by students and, sort of our next generation. And I think, a couple things. One, everybody wants people to be healthy. Everybody wants people to be healthy. There's some disagreement right now about how you get there. And unfortunately, there's some disagreement on what, how you get there, basically. But I can't think of a single person who doesn't want to be healthy themselves, doesn't want their loved ones to be healthy. So people are always going to want that. And to have that broader impact at the public health level is so important. And it's an incredible community. I was trying to emphasize that. I think people are so mission driven. And I think what I would say to the next generation is, and part of my emphasis and the way we're trying to, is we have to rethink things. We have to innovate, which is your theme of the day, which is great. I think it is a field, and I think the field and/or government, we've been slow. We are the opposite of nimble. We are slow to change. We want our data to be perfect before we can share it with anyone. We have to change, I think. We have to be adaptable, and the pace of the world changing around us, we have to try to catch up, and we certainly were forced to do that during the pandemic. But I think it's a big culture shift too, but I think the next generation can help us do that. And most importantly, I think all of you can help us communicate better, because I think, you've got people in my generation older trying to come up with messages or figure out how to work our social media, and I'm thinking, also hearkening to my teenagers rolling their eyes at me, but we need the rest of you in this next generation to help us work on this and work on communicating to people. We have to be able to do both. We have to have posters like this for our colleagues and medical journals and public health journals, and we need to be able to translate that to your neighbor, to the legislator who's making funding decisions, to other policymakers, and to, if those of you who do any clinical work, to the patients in front of you, so they understand why this research and data you've worked on, why it matters to them. We're really good at all the technical jargon. We need to work better on how you just speak plain English or whatever, and modify to the language people speak, but really meet people where they are on their communication and information needs.
Great. So I'd like to turn it now to questions from our audience. Let's see. We have some mics coming over here.
Hello, my name's Andy Short. I'm a very old EMPH student. It was great to hear you. I'm curious, on the messaging misinformation front, what resources are you bringing to bear on that? And is there are you hiring an army of TikTok contractors? Is there a structural issue? As in, does the message need to come from outside the department or outside the state? And how do you kind of influence that?
Yeah, no, perfect question. And let's see, we finally have a TikTok account, which is an accomplishment, and not every health department does. So we have one, and I think we do have a small team of social media. We don't have the army that we need, which is where it goes to networking. You need to have a network and/or a network of networks, because as you also said, there's only so many people that are going to listen to me as, state public health officer. Many people will much better listen to their leader in their community, people they've trusted for years. Or, it's interesting to me too, actually, my husband's a primary care pediatrician, and for a long time, and the surveys still say that people trust their, whoever they see more commonly over their life and one-to-one, which makes sense, their primary care provider. But even that, I think I'm very concerned, is being overridden by influencers in social media. So my husband has patients who come to him now and say, back to vaccine hesitancy, I saw this TikTok video and now I'm concerned, and they vaccinated their other two older kids, and he's been their pediatrician for 15 years. And yet we have work to do, is really the bottom. But we made some progress, and I think that is what we're trying to build with your local epidemiologists, as far as and Fact Coalition, actually, like building this network and then network of networks, and how do you kind of sort of respond with what's the core information, and then how do you kind of translate that into what that community kind of they can adapt it for their own community, but you need sort of those champions and network of champions who actually do trust sort of a common source of information and to counter all the other information that seems to be out there.
Mike's coming around.
Thank you so much for joining us today. My name is Yoshira Nellis Van Horn. I'm an assistant professor here in Environmental Health Sciences. My question is also related to this, but huge fan of your local epidemiologist and also the Why Should I Trust You podcast. Actually, both inspired me to start my own Substack because I thought, I think some of us are divided on the whether it's our job as scientists to communicate with the public or not. Personally, I think it is. But really getting to some of the points brought up here, how I've been thinking a lot about how it's always like, oh, scientists should speak to communities. Our communities need to listen. We just need to educate them from more on these issues. But at the core of it, I do think some of their concerns are legitimate, right? From both sides. And one of the things that I've been trying to grapple with is how do people in power making decisions, whether it's politicians, I'd argue that both of you are in power making positions. How do you grapple with the idea that it's those people in power that we actually need to educate with listening to scientists or listening to communities? I always feel like all of these like science communication fellowships, deliverables, et cetera, but I have not seen a lot of talk around, again, policy making decisions, Congress people, their staffers, like really getting at the core of like, hey, these are the people you should be listening to. Like, this is how you listen to scientists. This is how you listen to communities. So wondering about any initiatives or ideas that you have to sort of push the line on that front, and less on like, if we just talk to communities a little bit better, or maybe in their language, they're gonna come and meet us where we're at.
Yeah, I think maybe at the core of what you're getting to also that I do think we need to do better is engagement. So there's communication and there's engagement, and those of you in the equity world know, right? There's like a whole spectrum of when do you actually get to true engagement? How do you engage the community you're trying to work with earlier in even what data to collect? And or in public health, we kind of do a needs assessment, but like, who are you asking like what the problem is? Are you asking the people you're trying to serve, or are you just sort of, I think there's that. If I'm understanding your question correctly, and then I think there are, and I'm learning more about, like, there are organizations, but they do seem more behind the scenes that are sort of working on, like, okay, bringing the research to the policymakers, to the legislators. But I think really back to like science and data. For that trust, I think it's really engaging the community earlier, and even again, data collection, data interpretation, before you go with the publication, even like, what do you want to know about this information we gathered from you and your community, and how is this going to change your life? And whether that's the clinicians or the individuals, or to really, which takes resources too, I will acknowledge. And I think we need to do that to have trust. I think we've lost a lot of trust.
Hello, Dr. Pond. My name is Curtis. I'm a current MPH student in CHS. I was wondering if you could speak a little bit about the FACT coalition building and sort of navigating the challenges of building a coalition, right? I noticed that includes like community-based organizations and community members, so I was wondering if there has been like challenges in making sure that their voices are heard, right? Especially at like such an institutional level.
Yeah, no, that's a great and important question. And I think it's interesting, having been at the local level and now at the state level, especially in a state this huge, to try to navigate that balance of how do we have some statewide consistency, yet also meet the needs of a lot of different communities. And then as far as coalitions, that is back to where I think coalition of coalitions is sort of the way to go, right? Like, I think, again, who people trust is the faces they know, that they see in their community, at their grocery store, at their faith-based organization, if they belong to one. but being able to really better organize like each of those networks to be a broader network and have some consistency, and have that be bidirectional also. Like, how do we better get information up about, what are the barriers? So a lot of what Fact Coalition, but it's very early, admittedly, and again, it takes time and resources and energy. So we're working on trying to get more resources but how do you listen to people and understand, like, what are the barriers? So we just passed this law, but do people understand that? Or is the pharmacy actually complying with that law because they're a national organization? Or, what's the workflow issue in the clinic for the access? And, there's just all kinds of other issues that you don't, especially in a rush, like when you're trying to get something across the line quickly, then you need to learn as people are trying to implement or understand, like, well, okay, what is coming up about this, or what are the barriers? And that's where if you can develop a more formalized network of networks, you'll be able to get that information more quickly and react to it more quickly. But I think it's still, local is still, and again, I have a lot of, I miss some of the local aspects too, and I think it's really important, again, to be working at different levels, and some of that trust is really at that local level.
Jack Needleman from Health Policy and Management. The word trust has come up, and I noticed it on your slide about partnering with trusted messengers. And I want you to I would really like a little bit more concreteness. I think as a scientist in the School of Public Health, one of my great frustrations is trust based upon expertise has declined substantially in the United States. So we need other sources of trust, and you've said identify trusted messengers and partner with them. And I'd like to know more specifically about who you are identifying as trusted messengers and what those partnerships are to make sure that those communication vehicles are being mobilized to get appropriate public health messaging out.
Yeah, I think concretely thinking about this Public Health for All Californians Together coalition. So at a start, and again, it's only a few months old. We just launched this in September. We are trying to bring together, like, at the state level, Covered California, sort of our UCSF colleagues, but then we brought in together, like, the California chapter of American Academy of Pediatrics. We, Michael Liu up at school, and I think convenes all of you from the different schools of public health, so trying to have our academic organizations, medical professional organizations. We're trying to get pharmacies, and pharmaceutical organizations involved. So, it's a mix. And admittedly, this is people who want to come forward to work with the California Department of Public Health. So they have to trust us to come. And I think, this actually probably wasn't your point, but the people that we want to reach the most are not coming to our coalition. So we still have to figure out how but I think then some of these other tools, like, okay, you can do things like social media monitoring, or you can come do focus groups in certain communities and work with partners on the ground to do that. But I hear you, though. I think, there's a new term, gold standard science, and it means a very different thing to you probably than to certain other people at a different level than us. And it's hard. It's really hard when words you thought of one way as a scientist are being used a different way. And I think that's where getting back to different layers and communities is where we have to understand, well, who are they going to trust? Because, and why?
Thank you so much for your talk. Philip Massey in the Department of Community Health Sciences. And my question builds on trust and engagement and communication, and specifically focuses on the convening of the health departments from across the country. Presumably, or I'm assuming many of them come from states that may be labeled red or blue or different colors. And when you all come together and are able to share those experiences and stories, I imagine some of those colors fade away. I'm curious what lessons you learn from other states and other health departments that may be experiencing something very different than what we are experiencing in California, and how we can build on those shared experiences to sort of reach a higher understanding or impact.
Yeah, I think back to communications, I think that's where we are learning a lot too about, yes, the communities that, where are they hearing resistance, and or what are words they've used that have really backfired, or and where we're learning things like, don't use misinformation anymore, use, I'm still getting used to this, like unfounded rumors or unfounded claims. So I think there's a lot, and which is why we did have that. It was still just the Western states, but we also have, and many of you may know, there's, in addition to APHA, there's a National Association of State Health Officials, city and county health officials. So we do learn from each other. And in California, we're very, LA is very different than the rural North and the Central Valley. And so, we did just do, our team with Cover California just went into the rural North to try to do more listening to and hear and understand, like, what are the things people do want to know, and what are the best ways the local sort of public health leaders who do know the benefits of vaccines, what are they finding that's successful, and where are they also seeing things that aren't working? So we are definitely trying to learn from each other. And I think coming together, health, I never imagined health could be so politicized, and we know it can, but this is certainly an extreme, right? I think, I mentioned, early in my career, I was doing a lot of pandemic planning, ironically, and during the 2009 pandemic, it didn't get political in the same way. It didn't get divided politically, but I come back to, and I think my public health colleagues certainly come back to, everybody wants people to be healthy. Like, you can't, so you get back to what are our common values? I do think across the state health departments, we are aligned. It's really when it's an interesting point too around, the other way, actually, it's Caitlin Genelina talks about, we all as public health and certainly scientists don't think any of this should be politicized. And you have to figure out how to engage it to some extent, because the third rail and the resources are under the control of, so it's a challenge though, I think. But I do think this is why we very intentionally wanted to broaden, and there's a lot of sort of behind the scenes work across, certainly public health departments.
So we have time just for one more question.
Hi, Dr. Pond. Thank you so much for your talk. My name is Kristen. I'm an associate professor in health policy and management, also in the School of Nursing, and I'm also a practicing nurse. And I was wondering if you could talk about what you think the role is of healthcare, so hospitals, doctors, nurses, healthcare organizations, and advancing public health right now. Because I think healthcare is a really important partner, and I've always felt that healthcare doesn't do enough to address population health. But when you were telling the story of your husband, and when I think about my practice, and among all the other things I have to do, now I also have to compete with TikTok influencers, right? Like, it's a lot to ask. So I guess I'm just wondering your thoughts on how healthcare should partner right now with public health.
Yeah, I'm so glad you asked that, and that it's, anyway, our concluding question. I have been thinking so much about this, and part of why the FACT Coalition is also, I think, and actually, admittedly, I think it's more heavy on the healthcare, health insurer side than community partners, but we're trying to now bring together our more traditional public health program partners with, but I think also in that prioritization piece I mentioned, I think the unique role of government public health is the protect part. So disease control, outbreak control, making our food safe, making our water safe. The prevention and promotion needs to be, we need the healthcare sector. You probably know, 2 to 3% of our health dollars in the United States are spent on prevention and public health. The rest of it is on the wrong end of the spectrum. So yeah, we need, and I think in seeing this boom and bust of traditional governmental public health dollars, I think the promotion and prevention especially really have to come from the healthcare side and other businesses too. So I think that is our other goal around collaboration and intersection of our sector. We have to do more cross-sector work, and I think the healthcare system really needs to improve. There's like community benefits. There is some work. There's community health improvement plans that at least all the plans that also have, Medi-Cal and managed care plans have to, so we're increasingly at the state level, which then I think is informing the plans and locally coming up with sort of combined requirements that are, overlapping with public health and promotion prevention. But I do think as far as resources, we really need to turn to the private sector and healthcare systems for the prevention promotion.
Well, we have come to the end of our time together. I want to thank you so much for joining us today and for a terrific presentation and fielding all these questions. Please join me in thanking Dr. Erica Payne. So now I'm going to pass it back to Professor James Masinko, who will tell you a little bit about lunch and the afternoon sessions.
Thanks so much, Ron, and thank you, Dr. Pan, for such an inspiring and really candid discussion. We really appreciate learning more about how our state is handling public health. I have the pleasure of announcing lunch. There are box lunches out in the lobby. There are some places to sit and some lovely tables where you can continue the conversations. We also have a beautiful rooftop in this building, and you can also go out to what is called the bomb shelter. I don't know why it's called that, but it's right outside the front doors, and it's also a great place to have lunch. Please, while you're picking up your lunch, take a look around at the student posters. They will be presenting their work. It's really interesting and cutting edge stuff. I think you'll all find something that resonates with you. We will come back here at 1:15. As you know, we run a very tight ship around here. So 1:15, we'll start with our next panel. Thanks, everyone. See you soon.
Welcome back, everyone. Welcome. And for those of you who are just joining us, welcome. We're glad to have you with us. I hope you had a good lunch. I hope you had an opportunity to see the terrific posters from our students. And we have a great afternoon planned. But we're going to begin by recognizing our Student Impact Poster Showcase finalists, two of whom will receive the 2026 Lester Breslow Impact Fellowship Award. Now, I want to thank the 2026 Lester Breslow Impact Fellowship Award Committee, comprised of faculty members Dean Emeritus Afifi, Professor Roshan Bastani, and Professor Mei Wang. Thank you so much. The award is given in memory and honor of Dr. Lester Breslow, a former dean of our school, beloved professor, and public health luminary. Dr. Breslow's pioneering work established the connection between health and lifestyle. It is now my pleasure to recognize the 10 poster finalists and to announce the 2 Lester Breslow Impact Award recipients. I ask that I'm going to call their names. When I call each student's name, that they come forward to receive their certificate from Associate Dean James Masinko. And please hold your applause until I've read all of the students' names. Adam Consul from the Department of Health Policy and Management. Angelica Barrios from the Department of Community Health Sciences. Isabella Cruz Vespa from the Department of Community Health Sciences. Jamie Millicent Lee from the Department of Epidemiology. Kevin Nguyen from the Department of Health Policy and Management. Serena Liu from the Department of Epidemiology. Tomoki Okuno from the Department of Biostatistics. Yi Fang from the Department of Environmental Health Sciences. And our 2026 Lester Breslow Impact Fellowship awardees, the top submission among doctoral students, Shu Meng Yan from the Department of Community Health Sciences. And the top submission from our master students, Yojun Cho from the Department of Epidemiology. Please join me in a round of applause for all of our students. Congratulations. So I'm excited for our next panel, which will address championing health equity. And it's my absolute pleasure to introduce the moderator of the session, our colleague Beth Glenn, professor and vice chair from the Department of Health Policy and Management. Please join me in welcoming Professor Beth Glenn.
Thanks so much, Ron. I feel like we should this is the hardest time to do a panel, I believe, right after everyone is a little bit comatose from their lunch, but I'm sure I can see we have a very engaged crowd. So good afternoon. I'm really thrilled to be here and moderate this panel on championing health equity, a topic that's really near and dear to my own heart. The panel will bring together 3 scholars, Dr. Allison Gemmel, Dr. Yoshiri Van Horn Cornelius, and Dr. Whitney Pirtle, scholars whose work examines how structural forces shape and produce inequalities and inequities in the population. So they'll each present some of their work in this area and share their perspectives on how we can most effectively work together to achieve health equity or at least move towards it. Each of the scholars will speak for around 7 minutes, and then we're going to have time for your questions, so please be thinking about them when you're listening to their words. Our first presenter is Allison Gemmel, Associate Professor from the Department of Epidemiology. Please join me in welcoming Professor Gemmel.
Great. So hi, everybody. Thank you so much for inviting me to be here today. So I'm a perinatal epidemiologist and demographer, and one of the areas of my research is actually considering how social and policy contexts shape maternal and perinatal health and their implications for health equity. Okay, great. So rather than focusing on individual risk factors, my work examines large-scale social and political disruptions, which I refer to as population shocks. And these shocks can include events like the ones shown here, such as terrorist attacks, high-profile police killings, periods of economic contraction, and even presidential elections. And these kind of events can generate stress and uncertainty that are widely felt across the population. And importantly, and key to this session's theme, these stressors are not evenly distributed or experienced. So populations that are more directly targeted or exposed often experience both higher levels of stress and greater vulnerability. And so while population shocks can affect health across the population, they may be especially consequential for pregnancy or during pregnancy. And we know from other research that pregnancy is a biologically sensitive period where exposures, especially stress experienced by the mom or the pregnant person, can affect fetal development and subsequent birth outcomes. And so their stress-related pathways can actually increase the things of risk like miscarriage, preterm birth, and even maternal morbidity. So importantly, because birth outcomes also shape health and development across the lifespan, these exposures can also contribute to longer-term and even intergenerational patterns of disadvantage. Okay, so in this talk, I'm going to focus specifically on socio-political stressors as a type of population shock, and there's growing evidence from our team and others that these are really important for pregnancy and birth outcomes. So what do we mean by socio-political stressors? These are events and policies that signal threat, exclusion, or instability, and in doing so can generate stress and uncertainty in people's lives. And one example I've studied is the 2016 presidential election, which was accompanied by heightened anti-immigrant rhetoric, racist rhetoric, the threat of anti-immigrant policies, and those in turn have been linked to increased anxiety among the Latino Hispanic population. And you can see here in the upper right panel, a New England Journal of Medicine commentary published around the time that really reflected this broader concern about the potential impacts, health impacts stemming from the election. And more recently, we can think about abortion bans as being another type of sociopolitical stressor, especially affecting maternal and perinatal health, not only particularly for populations experiencing barriers to care, but also in terms of potentially providers facing increased legal risk for providing evidence-based pregnancy care. So taken together, this work points to a potential pathway through which broader social and political environments can shape maternal and perinatal health. And I'm going to go through 2 examples from our work. Okay, so this is the first study that was published actually in 2019. And it was one of the early studies to show that a major sociopolitical event, here the 2016 presidential election, could actually translate into measurable health impacts in terms of birth outcomes. And so using national birth certificate data, we examined whether the 2016 presidential election was associated with changes in preterm birth, specifically among Latino women and immigrant Latina women, given their greater exposure to stress related to the rhetoric surrounding the election. And from a study design perspective, we treated this election as a natural experiment and compared observed trends after the election to what would have been expected based on prior patterns. And what we found was about a 3 to 4% increase in preterm birth among Hispanic birthing people and immigrant Hispanic birthing people. And importantly, we didn't observe the similar increase in non-Hispanic white populations. And some of our follow-up work related to this actually implicates a stress mechanism that's underlying this. Okay, so more recently, we've been studying the impact of abortion bans on various health outcomes. This is actually NIH-funded work. And so I'm going to just highlight one of our studies here. This was published last year, and it received quite a bit of attention. And this was one of the first studies to connect the abortion bans connected to Dobbs and other heartbeat bills and their relation to infant mortality in particular. And what we found was about a 6% increase in infant mortality in states that effectively banned abortion. And this corresponds to approximately 500 excess deaths that we wouldn't have expected had these bans not occurred. But importantly, and again, speaking to this session's theme, this was actually one of the first quantitative studies that found evidence of disproportionate harm based on the policy. We found larger increases among non-Hispanic Black infants specifically. So you see that 11% figure there. That is quite striking and quite large. So it's interacting with these underlying and long-standing disparities and making them worse. Okay, so taken together, my research shows how we can use the tools of demography and epidemiology to generate really policy-relevant research on health inequities. And so we're leveraging this large-scale population data, and we're detecting relatively rare but consequential outcomes like infant mortality. And using causal inference approaches, we can move beyond description to estimate the effects of real-world sociopolitical stressors. And because of these real-world shifts, this work's been really useful in informing policy discussions. So I'm actually working with a senator's office right now about the findings that we have related to our abortion-related work, or abortion work. Okay, and then finally, more broadly, I think these approaches that I've discussed here today bring a rigorous population-level lens to health equity, and it complements the work that we're going to hear from our other panelists here today and the work that is ongoing all the time at the School of Public Health. And to get taken together, they all speak to identifying those upstream factors that we talk about so much in public health to address health equity. So thank you so much.
Thank you so much. So our next presenter is Yoshira Ornelius Van Horn, Assistant Professor in Department of Environmental Health Sciences. So please join me in welcoming her.
I can't actually see the timer because there's a height, thing that I'm very proud of up here. So just letting you know. Thank you so much. My name is Yoshira Nels Van Horn. I go by Dr. Yoshi. So also shout out to a lot of the students that came out to support the talk today. I am a first-generation college grad, and I'd like to start off always with really a little bit more about my background and how I made my way into academia. I grew up in Phoenix, a proud daughter of Mexican immigrants. I never thought I'd moved out of Arizona. I was like, I'm gonna, be here forever. Eventually, took a postdoc at USC, got my first faculty job at Columbia, and then the doors finally aligned, and UCLA had an opening because I very much consider myself a West Coast girly. I very much view my role as a researcher as one working with communities to advance their health issues, right? And so overall, I kind of view my current position, my current role as a researcher at this intersect of working at the research, but also in the policy and process and supporting the movement/community. If you would have asked me what I research a couple years ago, I would have given you a very different answer. I now answer that I research everything that has become illegal. Environmental justice, health equity, structural violence, structural racism, all of those things. And more broadly, I work on this to really hopefully advance health equity by developing strong community-driven research collaborations. So currently, there's quite a few ranges of things I focus on, particularly environmental stressors. So I work from anything with metals exposures, pesticides, air pollution, looking at enforcement of national federal environmental regulations. But I wanted to focus on two of my currently active projects. And so one of them is looking at the impacts of this previously thought banned pesticide. So the rest of the world has banned it except California. I'll let you sit with that. So research from our group has shown that not only is it still being used here at disproportionate levels, but that the facilities that spray and use this pesticide are also located in communities that we would otherwise know as environmental injustice communities. I've been working with the Impact Project, which is a coalition of environmental justice orgs in California, and also some of the state Congress people to advance and inform the currently proposed rule by the South Coast Air Quality Management District that will hopefully bring regulations on enforcement and reduce exposures for those communities that live near or next to these facilities. I was just in South Dakota for this other project called What's in the Air, engaging Native American youth in the Northern Plains to reduce air pollution. And so that one, again, started a couple years ago, but only 15% of federally recognized Native American communities currently have capacity or are allowed by the federal government to run their own air quality monitors. And so with this project, we wanted to not only, again, advance knowledge and close those data gaps on air quality, but also engage the local youth. And so this is a picture from when we launched the first ever air monitor in that area. And again, just came back from there from doing an event where we had a table doing an outreach event where there was about 300 middle and high school students that came to learn about environmental health. Oops, sorry. Lastly, we really wanted to highlight this new project that started about 1.5 years ago. And so it's a collaboration funded by Bloomberg with the organization called Rice St. James. They're out of Louisiana and Columbia University. And we were approached by Rice St. James, who's a grassroots community org in Louisiana. They are located in St. James, which is known as Cancer Alley. High disproportionate rates of cancer, some of the worst air pollution you'll ever encounter in your life. A lot of it due to the high density placement of petrochemical facilities in their area. And so one of the things when we met with them, they said that, look, we know the air pollution's bad. People have been coming here and measuring this. It's documented. We know that for the, even though there's not a study that's taking place here, we know that there is documented health outcomes with this, right? We know that it can lead to preterm birth. We know that it is devastating for cardiovascular health. Again, we also know that it can lead to increased rates of cancer. But what we don't have is this local study here that politicians and people making decisions always ask us for. And so what we did, went out there, met with them to really understand, okay, what would a community-based participatory research study look like in this area? And so with them, we decided to start through a pilot study where we would be collecting urine and measuring volatile organic compounds that are known to be from petrochemical industries. And so we went out there last year, finally launched the study after many administrative burdens. Anyone that's ever done fieldwork knows, institutional review board, purchase orders, whatever else is out there. It takes a lot to actually be on the ground. And so finally, in June, we launched it where we recruited 5 participants as a proof of concept, collected urine every morning for a week, and then analyzed it for over 30 metabolites of VOCs that are potentially emitted from these petrochemical facilities. In January, we went and did a community report back. Earlier, if you were a part of those panels when we were talking about really doing that communication and not waiting to the peer review process, this is exactly how we approach and how my lab approaches and how a lot of my collaborators approach our science. And so really just highlighting, again, cutting edge data coming out from this group, really validating what these communities have always told us, that they know that they're overexposed, but they just haven't had that health research study that their politicians, their people making these decisions have told them, right? And so overall, seeing that the VOCs measured in urine in our sample is higher than what we would consider a general national representative sample using data from the Center for Disease Control National Human Examination Survey. These are just highlighting a couple of the VOCs we see. And I want to give a huge shout out to all my collaborators who've either helped me with study design, supplies in the field, all of that. My lovely lab group, I know some of the students are here who've been super supportive, and current support and affiliations. Thank you.
Thank you so much. So we have our next speaker, Dr. Whitney Pirtle, who is Assistant Professor in Community Health Sciences. Please, really welcome her.
All right. I am so honored to be here as a part of this health equity panel. I consider myself a critical race theorist, which has tried to be made illegal, so a lot of my work is in that lens. I have interdisciplinary training in sociology and Black studies that I try to bring as much as I can into public health. And so I'm going to talk today about the work that I'm doing, which is really thinking through how, why, and to what end racism is and remains a public health crisis. Why racism? Well, first, because it's everywhere. It is in the air that we breathe. I find analogies really helpful to explain complex topics, and this is one by Beverly Tatum that likens racism to a smog in the air. Sometimes it's so thick it's visible, especially in communities of color. Sometimes it's less apparent, but always day in and day out, we're breathing it in. Racism operates as a pervasive hazard for our health and increasing impact towards those most exposed. Racism is also everything, as our definitions of racism often instruct. This is one put forth by JAMA in their recent piece on offering definitional guidelines, which says that racism is structures, policies, practices, and norms resulting in differential access to the goods, services, and opportunities of society by race. Racism impacts our health all at once. There is decades upon decades, some of which was touched on already, that shows racialized disparities across nearly every single health indicator through multiple disease pathways. According to the former CDC director, racism is indeed a serious public health threat that directly affects the well-being of millions of Americans. Yet, research in health-related fields often remains underdeveloped when it comes to defining and measuring and explaining this race stuff. Boyd has reminded us that the bar, and I'm quoting, to publish on racial health inequities has become exceedingly low. There's no uniform practice regarding the use of race as a study variable, and little to no expectation that authors examine racism as a cause of residual health. 2 recent reviews highlight this in different ways, I think. There was a review by Martinez et al. In the American Journal of Epidemiology that did a meta-review about epi publications and find that only a portion explicitly name race and ethnicity, and of their 400 analytic sample, only 4 studies explicitly defined race and ethnicity, which is therefore risky when we're doing this sort of work. And the majority of the studies did not state how race or ethnicity was actually coded or measured. When we think about racism, this piece by Bailey et al. In The Lancet looked at over 5,000 articles that were returned when they said, let's study race and health. But if you substituted race for racism, structural or systemic, 0.04% were returned. So we know racism is everything, everywhere, and impacting us all at once, but how are we actually measuring that in the work that we're doing? That's what I'm interested in. So this is a working analogy that I've been playing with myself, coming off of the highly acclaimed 2022 film, Everything, Everywhere, All at Once. If you saw the film, it's about everything, and there's the everything bagel floating in the air, and it represents sort of the complexity of life. And when it becomes so overwhelming, you might get sucked through the black hole and end up on a rock. And it's sort of, that's what happens, right? And it sort of offers a caution, I think, in the film, but as I'm replying to us in this room, that when race and racism is treated like an everything bagel, if applied wrong, it can become a black hole in our work, which risks the problem of diluting concepts by overgeneralization and underconceptualization, which leads to a lack of clarity and rigor about this race stuff that we know really matters. So what I think, as someone with this interdisciplinary training, is that returning to a deep study of theory is one way we can benefit this work. I am a critical race theorist. I pull from that and these other sort of critical theories of race and racism, and am influenced often by my predecessor, Dr. Chandra Ford, who put forth the public health critical race praxis. And so my work has really been about exploring different ways we can use theory to inform how we're conceptualizing and measuring and then later addressing racism. I've had papers, for instance, that have looked at how skin color showcases a larger effect of perceptions of discrimination when linking discrimination to health, or papers that have looked at American Indian or Native populations and find that there's a variable nature in which people identify with that population, and what would it look like if we captured race over time to really get at the social constructed nature of race. Or even if we know that these racial disparities exist, how might we capture racism at the structural level to show that it operates beyond interpersonal discrimination and therefore exacerbates these findings that we find. So right now, I'm really trying to look or offer a model for how we think about race and racism as multifaceted, interconnected, and remaining a totality in structuring our lives and our health. So in my sort of theorization, I'm thinking about specific theories and or tenets of critical race theory that would therefore guide how we are conceptualizing race, for instance, as multifaceted. Maybe we need to go beyond the racial categorization and look at racial identity. We might look at skin color if we're really trying to get at perceptions of discrimination. We might think through relational dimensions of ethnicity to get us beyond acculturation. And in addition to being thoughtful about the race category, I say that our research is more refined and woven into the theories when we capture racism as a totality. Again, that includes looking at the structural level, laws and policies, looking at discrimination, but not just as a one-off, maybe spillover or vicarious effects. And even though racism is fundamental, primary, and an ordinary cause of health disparities, it doesn't operate alone. We have to account for the interconnectedness via intersectionality, maybe looking within and across groups, interactions between subgroups, or using the theory to actually think about structural gendered racism or racial capitalism in the work that we're doing. Now, I used Notebook LM to make this, and it definitely is giving everything everywhere all at once. So I don't know how helpful it is. But the idea, again, is that race and racism is central to our lives and to our experiences. We have a set of theories that are linked to the measurements that we use. In terms of practical implications, I co-authored a comment reply to that American Journal of Epidemiology piece with Dr. Ford that offers some tangible implications, such as requiring journal recommendations of race met before publishing, working with collaborators who have expertise in an area, using theory to create new measurements, and explicitly naming white supremacy and racism, which is sometimes seen as a threat in and of itself. So thank you all for having me in this space. But just in terms of where I'm headed next, really influenced by folks in this room and the department that I'm in, I am proposing a study that is listening to those on the front lines of fighting racism, so community health workers of color working in communities that have been underserved and trying to figure out what language in which they use to identify the structures of racism and how that might in turn reflect our definitions and measurements as researchers. Thank you.
Thank you so much, Dr. Pirtle. And if everyone can come up from this session, and we have time for your questions. And there's folks coming around with the microphone. So questions for the panel. A few on this side.
Hello, everyone. My name is Curtis Wong. I'm a MPH student at CHS. My question for you is that this information and research that y'all do is important, right? And it's sometimes really complex and complicated. What is our role as researcher to be able to disseminate this information to our community members, right? And then the second part is sometimes our community members will ask us, what's next, right? We have all this tough research, so how do we mobilize, right, this research in order to make actionable changes?
An easy one to get started.
I might have to ask you to repeat some of the stuff. So, dissemination is, it's like place and time, right? I very much view it as like an iterative process. And so there's different levels for that. For me, particularly when the community partners involved in my research as co-investigators, right? We're having those weekly meetings. They know everything that's going on as part of the study. The participants that actually are involved in my study, they receive results, what we call results report back of research, right? So they receive packets of these were your levels. This is information. This is how you can reduce your exposures. Then there's the level of community dissemination. And so I mentioned very quickly that in January for the Right to Breathe project, we went back and presented the results of the study, and also talking, part of that was one, to give information back to the people in that community. And so it was hosted at a public library. Secondary to that was also, we're gearing up for our second phase where we'll be launching the follow-up bigger study where we'll be recruiting 70 participants, all in the hopes of, again, building out a bigger cohort. And then there's other things on dissemination like, newspapers, talking to the media, publishing, that is still very important for us as researchers to do the publications, right? So I'd say for the dissemination, it just comes in a wide variety of there's a lot you could do, but I think being cognizant of the investment of here are the levels, this is my goal with this, and building out is super important. I'd say I think you were talking about capacity or mobilization. I am of the mentality that communities are already empowered. They don't need me to give them advice on what their mobilization efforts. They know way more about any of these bills than I'll ever know. What they want is more on the technical help. On hey, how do I interpret this? Is there evidence to support that we are being not only poisoned, but over poisoned by these chemicals? So that's sort of how I see my role as a researcher. And particularly that all the partners that have ever come in and hey, where can we go from this? They know the landscape more than me. They know their state people. They know who's in charge. They know who's leading their public health departments. They know who's never answered them. And so that's all the stuff in terms of mobilization. Again, research helps support and provide evidence to things that they've already know from their lived experience.
Great.
I'll just say, I think that's such an interesting question for someone like myself who works with more population level data. And so we're not doing the traditional community-based research, but what we are doing is I make sure that we partner with collaborators. So I didn't show all the people that have also, they're the authors on the studies. and they're more closely connected to some of the communities, especially for the Trump papers, for example. But what we've done with the abortion work is we've taken the more policy oriented stance. And so we put on an event in Washington, D.C., for example. We've worked with advocacy groups around policy making and providers and working with them. And so that's been really important from our end. But it's a great question.
Yeah, I appreciate both of y'all's perspectives and experience in that. I would just say, as someone who spends a lot of time thinking about theory and clearly language, I think that's been some of my approach to make sure even the ways in which I'm talking or the students I'm training are talking, going into communities is not harmful. And the use of analogies, I think, is great. I know we talked a lot about art and public health practice last week in the school. I think that's great. I did a theoretical piece on racial capitalism, and if you've read any Black studies scholars who write about racial capitalism, it's very dense. And so my goal was try to make it accessible, and one way I did that was through collaborating with someone to make a comic to tell a story through it. So I think I'm constantly trying to listen and learn and apply that in terms of getting it out there.
Great. Additional questions? I think there was one behind you, Brad. Thanks.
Hi, Tom Bellin. I'm on faculty in biostatistics. Maybe specifically for Allison, because I noticed some of the co-authors on the abortion paper in particular were colleagues, friends on our, but I was maybe going to ask more broadly about the role of measurement, the role of statistical analysis in your work, and how you see that as a component of your efforts.
This is a great question. So when you're doing this kind of natural experiment policy shock study or these types of studies, you can use off-the-shelf methods that we learn in our training, but it turns out for abortion, it's very difficult. And some of those methods, the assumptions are violated, and there were other challenges. And so it was really key to this project to partner with actual statisticians that are at the forefront of methodological advancement. And so that's been really key to this work, and they are advancing this so that maybe people can study other challenging shocks or exposures. I was just going to say one more thing. Oh, we also wrote a methodological commentary for folks that are studying the impact of abortion bans, because I think a lot of people just weren't aware of the complexities of the abortion landscape prior to Dobbs. And if you came at it kind of naively, you would kind of come up with different results. And so one of the key takeaways from that commentary, I hope when people read it, is that we need to collaborate. And not work in our silos. And it's really important to have both the substantive expertise, but then the cutting edge methodological expertise.
Great. Oh, we have a question here.
Thanks. Masoud Agahi. I'm a practicing doctor.
Can you speak up a little, maybe?
You hear me okay? Do you hear me? Okay. Masoud Agahi, I spoke a little bit earlier. I'm a practicing physician, surgeon, but also got an MPH only a few years ago after 20 years of practice here at UCLA in the executive program because of the lack of knowledge, public health knowledge among the medical community. And I'm here to tell you that continues to be a problem today. But anyways, in the course of my work after graduating from the program, I've actually stayed involved in practice of public health through some projects that we've been conducting. Among them have been actually one of my mentees was a winner of a Health Equity Challenge here at UCLA, and we partnered with a community-based organization, United American Indian Involvement and Native American group here in Southern California, to build up their community health worker program. And this was a CDC program, and we did the evaluation for the program. And ever since then, actually, this has grown into multiple directions. And the reason I wanted to bring this up is actually leading to a couple of questions. One for for you regarding the Native American studies that you're involved in. Something that we came across was Evidence for Actions, which is a program sponsored by Robert Wood Johnson Foundation. And they have an ongoing study of ways of knowing focus groups. And this is to get the participation of Native communities, but in general, other ways of collecting data than the scientific method that we're familiar with. And I thought that's actually a very, very important way of being able to produce research that's useful for such communities. And I wanted to know your perspective on that. And while I'm talking, I might as well address my other question regarding racism and its measurements, which is another topic of very much interest to me. I've actually come across some MRI, functional MRI studies of the brains of subjects in response to racist comments or pictures or things of that sort. And there's actually documented, measurable, double-blind studies that you can actually measure racism, if you will, on an MRI. Are there any other quantitative methods that you're familiar with, objective methods of measuring racism? Thank you.
Or I guess that's the link between racism and health, maybe.
No, I mean, thank you so much for that question. I think I'll start off by saying that, so my first, so I grew up in Arizona, but even though our counties there are named after Native American tribes, I didn't realize that until I went to college. And so the educational system of like you even knowing who is like Native American, the history, all the stuff that's been done to them. And when I say stuff, I mean, you know, right, colonization, removal of their homelands. I didn't know that until much later in my career. I ended up being, for my dissertation, I just happened to have been advised by two amazing researchers, one of them who happened to be Navajo. And for my dissertation, I ended up looking at a huge mining spill that happened and affected the communities of Navajo Nation. Really, it wasn't until then that my ideas of what was health or how to even measure health just grew, right? And so for a lot of us that aren't haven't worked with communities, other communities, and just are used to what we would call Western ways of knowing, I viewed health as like, oh, I don't have a disease, I'm okay. But really their knowledge and how they view their connection to the environment, to animals, to the spiritual world, it really, I can't even put it into words. I think researchers have tried, and no offense if this is one of you, that, you know, I think public health eventually had a competency around One Health. And really what I said was like, well, you know, those are things and indigenous ways of knowing. But I'm glad that the Western world has finally caught up to what is, you know, all-encompassing health. For them, there is quite a few varieties, and I think it'll vary by community. There's 576 federally recognized indigenous communities, so many more state recognized, and a lot of them still fighting for recognition. And so the way they approach even just knowing or methodologies or, you know, what we call traditional ecological knowledge is so vast. So I can really only speak to my experience with two of them and how we've gone about collecting some of this information, either through what I think we call them focus groups here, but they would be calling them like talking circles or listening sessions. And so all of those, again, methodologies that emerge from those communities, but the verbiage or the definitions just becoming different. And so I think if anything, what I've learned is that just because I've worked with one of them doesn't mean I know, you know, all 600 plus of them. But I'm glad that, again, your student and the work that you're doing, they're getting that information and really being able to support those communities through their work, because it is one of the communities that I think we tend to, it's really hard to partner with them for many reasons. But again, in terms of health equity, there's so many things we could be doing better.
Yeah, and I'm really excited to go look at those MRI studies. So thank you for sharing that. I mean, I think the field of sort of the study of racism in health is interesting in that, like my colleagues are talking about, I would say communities of color, scholars of color have been naming racism for decades, but how we have actually captured it in our research, I think, has lagged. And so oftentimes it was looking at differences in whatever health outcome and understanding that there was some race effect left over that was unexplained. So racism became that unexplained thing that's in the air. And then I think it's been a stronger push to try to capture how we might actually how we might use survey indicators or other models or even like difference in difference models. I'm thinking about of these shocks to actually name how racism is operating at multiple levels. So the research might say, everyday discrimination scale, how often are you followed in a store? How often are you told you're not worthy to be here? Or have you had a major life racist event? So you can measure that attributed to racism. But folks have done, I'm thinking about my former student who did look at Ferguson, using difference in difference models and looking at women in the counties closer to Ferguson and further away, and those women who had birthed closer and after Mike Brown was killed had worse maternal health outcomes, and that's like a community exposure to racism that we can better name, or capturing some of these policies that have been put into place. And then I would say though that you can also look at sort of shock factors, right? Expose somebody. If you look at exposure to racism, that it might have an immediate effect, but oftentimes it's long-term and it's cumulative. And so trying to figure out, did this one event directly impact one health outcome that we're measuring in a lab setting doesn't really get at the full nuance of our racialized experiences. And so I think it's such a complex topic to study with so many opportunities to build out these collaborations, to listen to communities, to refine our quantitative and qualitative skills to really continue to name racism in its many forms, but to use those skills to then offer stronger definitions that are refined and applicable. And I will also say that racism doesn't operate the same in each community. And so I think that sometimes we might slap on a measure of racism and say, it had no effect for this folks. But that's because they're racialized differently and how they're naming a particular domain of racism or experience might be different. And so I just think there's so much to be done, and it's really exciting that folks are involved and can actually name racism as a cause with, a little less maybe pushback here and there, because there's just so much to be done. So I'm excited about that in the face of the permanence of racism.
I think we have another question over there in the corner. Yeah.
Thank you so much for your guys' time and your guys' explanations on your research studies. I have a quick question. Given how rapidly glyphosate, which is the main component in herbicides like Roundup, was increased in the US, I think the settlement was proposed February 17th, and then the executive, literally 24 hours, was approved. Given that order being pushed the next day, what are the strategies public health can realistically deploy in real time to detect, mitigate, and communicate risks from environmental exposures that may have delayed but serious health outcomes like adverse birth effects and long-term health effects?
About glyphosate in general, or is that the specific? I joked around earlier that I was going to be asked about how to solve world peace. This is what it feels like in terms of rapidly. So for those that don't come from an environmental background, glyphosate is a pesticide. It has been associated with adverse birth outcomes, so I think a lot of stillbirth or low birth weight. I think it's also been looked at in the agricultural health study, so lots of documentation of its adverse health effects. I may be wrong on this, but I want to say that a lot of European countries have actually been successful in banning it. And then a few years ago, there was this like huge lawsuit. So glyphosate's also found in Roundup. So there was this huge lawsuit where this person said they attributed their cancer to their glyphosate exposure. So I don't know if that's the settlement you're talking about, maybe something else. Anyway, there's a long history of this ongoing back and forth. And so, yeah, I mean, communication of the public health professional, I think whether it's glyphosate or, current things of like measles outbreaks, the vaping, right, that happen and people becoming very ill from those. So I think those public health emergency communications is sort of a strategy, but like I wouldn't be able to tell you how best as public health professionals because I can only tell you that from my like a research standpoint. And so I say that because I think the communication, whether you're working for a local health department, whether you're involved in an actual organization that pesticides was their thing, is going to look very different on that communication, right? The only really the recent example I have on where I was asked to comment on something that I felt very nervous about because I hadn't actually read the report was the environmental working group put out these are the top 10 fruits and vegetables that have high levels of pesticide. I hadn't actually read the report. I knew about previous reports, but I was asked to comment on ways to protect yourself from pesticides. And I was like, well, this is my area of expertise, but also, is anyone going to give me the report? Like, I don't know what's going to come out. And so I ended up commenting on it along with a bunch of other colleagues. And I ended up getting messages from all of these different people being like, what fruit should I avoid? Like, is this hard for my child? And it ended up like sort of becoming this like monster in itself. Anyway, all to say that I think, I don't know if do we offer a public health communication course? Okay, apparently there's a public health communication course. I also say that I think a lot of public health agencies now have like people you have to vet through things. And so you're not allowed to comment as a professional unless you've probably vetted it through your communications office. And so I think there's a lot of different levels of what it is going on. There's also just too much, like there's so much news going on. And so when you're asked to comment, I think on these, when vetting it through whoever is supposed to be your communications plan, but you probably also should have a communications plan prior to this emergency situation that you're asked to comment on. So again, there's lots of ways you could go about it, but I would probably also say sticking to what you feel comfortable is in your area of expertise, and there's might be some things that you want to comment on but feel uncomfortable, and so that's sort of where I try to be very mindful of like, okay, is this within my area? Is this not within my area? And what are my hard limits of like, I'm absolutely not responding to that.
Great.
I don't know how much time.
I think we do have to wrap up. If you want to just say like maybe if you want to say. Okay. Yeah,
From a
that sounds
research
good.
standpoint, what I heard from that question was also, what if these effects are, longer term? And this is why I think we need to invest in data infrastructure. We need the prospective studies, but then we also need to leverage the data that we have. And for me, I tried to obtain hospitalization data from one state, and I was denied that in the current administration. So I think we also need to be upfront around these data challenges. And last plug, life course perspective. Right? These exposures that people experience over their life, they take a while potentially to manifest into disease. That's why I always try to teach about that perspective with my students.
Great. I think we're at time, but thank you so much to our speakers and all of your great questions. And I guess everyone gets points for bravery in this space, especially right now, given all the challenges. So thank you for all your work. Now we have our next panel, and it's going to be moderated by my colleague in environmental health sciences, Dr. Rachel Jones. So let's welcome her.
Thank you. Welcome, everybody, and thank you for joining us today. I'm going to be moderating the last panel of the day, which is focused on protecting health in a changing physical environment, which again is another topic that's recently come somewhat taboo, climate change and whether or not it's happening. I can't believe we're actually debating that, but it is a debate in some circles, probably not here today. But climate change continues to create public health emergencies for our communities and our society at large, whether that be because of the frequency of extreme weather events, shifts in our day-to-day climate experience and health, and we are working through the process of learning how to adapt and potentially mitigate these approaches. And so I'm excited to have our three speakers here with us today, and I see they've all come down to the front. So our first speaker is Catherine Leafheit, who's an assistant professor in health policy and management.
All right. Thank you so much for having me. Can everyone hear me okay? I wanted to start by saying I feel like a little bit of an interloper on this panel. I typically study policy environments or social environments, so the physical environment is something that's a little bit new to me. That being said, as a housing researcher, I've felt compelled lately to start thinking about the climate crisis as it interacts with the housing crisis. And I have this simple framework. It's kind of going forward without my... Okay. I have the simple framework to kind of explain the connection. So there's the obvious, which is that we have climate-related disasters which result in housing loss, displacing people, resulting in housing insecurity. We also know very well here in LA that climate-related disasters can mean that people lose their places of work, which makes it hard to pay rent, which results in housing insecurity. And then there's kind of this underappreciated level where, people lose their housing and then they tax what is already an overburdened housing supply. So we don't have enough housing. More people flood into rental housing, driving up costs for everyone. So all to say that, climate-related disasters certainly have direct impacts on health through environmental exposures. I'm proposing that they also have these indirect effects via housing insecurity. And I just wanted to share 3 related studies on this topic. So the first is one article that recently came out. And basically, we looked at this question of, we know nationally that housing or homelessness is increasing across the board nationally, but also in particular states. And those year-to-year rates of increase are actually pretty variable between states. So we wanted to understand what factors contribute to year-over-year changes in homeless counts. And we tested a lot of the kind of popular explanations that you find in political discourse or public media. So we put immigration rates into the model, we put housing costs, we put climate-related disasters. In recent years, the rollback of pandemic-era housing protections are also kind of a major part of this discussion. And we found out when you put all of those things in a pretty simple fixed effects model, the 2 things that came out as significantly predictive of year-over-year change in homelessness, so these kind of acute increases in homelessness, were the rollback of eviction moratoria within states, and then also climate-related property damage. So this graph here shows year-over-year relative change in homelessness for a typical state in the last 5 years. The black line is the observed year-over-year change for an average state, and then the green line is what we estimate we would observe had there been no climate-related disasters. So for example, for the year 2022, the typical state saw an 11% increase in homelessness relative to the previous year. Had there been no climate-related disasters or property loss, that would have been 8%. Next up, I wanted to highlight some work from a really talented postdoc I'm working with. So Patrick Smith is with the National Clinical Scholars Program, and he's been analyzing data from the LA Barometer survey. So I really don't know what's happening. So Patrick's been using data from the LA Barometer, which is a subset of the Understanding America study conducted at USC. And he's running these difference in difference models that compare the change in self-rated mental distress and physical health between people who report wildfire-related housing disruption, so either housing loss, temporary evacuation, housing damage, versus people in LA who did not. And he sees that housing disruption was associated with a 2.7% significant increase in fair or poor self-rated health in the 3 months following the LA wildfires. And then also suggestive evidence that sort of the mental health impacts of housing disruption last longer, so up to a year after the wildfires. And then finally, I wanted to talk about this work that I'm doing with colleagues at Drexel University and also the California Department of Public Health. So the CDPH had leftover COVID funds to try and prevent the spread of disease in vulnerable communities. So in this case, they really wanted to work in shelters, congregate shelters for people experiencing homelessness, where we know people are crowded into tight areas, disease can spread quickly. But it struck us that if we installed portable air cleaners, high quality portable air cleaners with extra filters, we could actually prevent the spread of infectious disease and also improve air quality and reduce exposures to environmental toxins and airborne toxins. So we distributed over 700 of these portable air cleaners all across the state of California. And we're doing a survey-based evaluation, just working with staff in the shelters to ask them what was their baseline air quality before they got the PACs, portable air cleaners. And you can see that people in general are reporting acceptable-ish air quality on a typical day, but then many of them are reporting unacceptable air quality during fire seasons. And there's also survey data indicating substantial needs for these types of interventions. So a large proportion of them are located in high wildfire risk zones, or many are near industrial sites, places with heavy road traffic, and actually only half had these types of access to these types of air cleaners before the intervention. And almost all of them are actually using the units. They have them on every day, and so we think it's a feasible and acceptable intervention. And we're now installing some of these objective monitors of indoor and outdoor air quality, just to understand how well it works on a more objective level. And I wanted to end by sort of saying I started this talk talking about a certain direction, what climate-related disasters causing loss of housing, but it's actually not unidirectional. I'm really not pushing any buttons. I wanted to note that, expensive housing markets and housing segregation often push poor and marginalized communities into areas of high climate risk and also climate-susceptible units. So the housing crisis in many ways kind of fuels susceptibility to climate-related disasters. We also know that housing costs fuel urban sprawl. So people move out and out until they're able to find a place that they can afford, meaning longer commutes, more air pollution. And so you can see kind of a direct relationship between housing markets and climate-related disasters. All to say that we need solutions to the housing crisis and solutions to the climate crisis, and these things are likely to be complementary and have really important implications for population health and health equity. Thank you.
That's okay. Okay, we're going to have a tech intervention for a moment. But I'd like to welcome up Falco Bergalgi Sophie, which I probably massacred that name. I blame that on my attendance at Montessori school. It's also why I cannot speak Spanish. I can't roll my R's. Anyways, he's an assistant professor in biostatistics. Why don't you come on up,
Thank
Falco.
you so much. Thank you so much. And the pronunciation was great. Kidding. Thank you so much. Thank you so much for having me. My name is Falco. I'm an assistant professor here in the Department of Biostatistics. And I have to say my way here was probably not the most direct one, in that I started out in a very convoluted way. That is, I started as a sociologist before I really got hooked up in statistics. And my love for statistics started because when I was 21, I got elected as a city councilor in a small town at the outskirts of Florence. And we had a lot of ideas, we had a lot of things that we really wanted to do. But I faced very early the fact that we lacked the data and we lacked the way to analyze those data to say anything about the policy that we were doing. There was a lot of good effort, good spirit, but we didn't know if the things that we were doing were actually going even in the direction that we wanted them to do. And so I decided after my undergrad to really go into statistics, and causal inference, I've seen a lot of causal inference today, was for me the great place to start, because I really wanted to find a way to evaluate these policies. And I really started investigating these topics. And one of the topics that I really got extremely interested in was the topic of environmental health, because a lot of the things that we're seeing out there, a lot of the consequences, the bad consequences that we're dealing with were really related to these environmental exposures to begin with. And another problem that we had generally was the fact that a lot of these policies were designed for this average person, whereas there is a lot of heterogeneity, and we really want to be able to target this heterogeneity so that we develop the most cost-effective policy. So today I'll introduce, and despite me being a biostatistician, I swear there's not going to be any formulas in the slides. I tried my best to have the lightest slides, but a causal inference approach, a causal machine learning approach for environmental health. So unfortunately, we know that in the United States, structural minorities are exposed to higher levels of air pollution as a baseline. This is a picture from a paper that was published in Nature in 2022, where they show, for instance, like how the Black population is actually exposed to much higher level. And once upon a time, there was this agency called the APA that said that no group of people should bear disproportionate burden of environmental harms and risk. And so we decided to try to test this hypothesis and really try to answer the research question on which are the characteristics of people, communities, individuals that are most vulnerable to this negative effect of higher exposure to air pollution. And in order to do that, the methods are very important. The methods are really a critical component of that. So here I just did a bivariate plot where on the x-axis you see how interpretable, how easy to read is a certain statistical model, and on the y-axis is how accurate. Of course, this is not like one size fits all. There are many nuances there, but I just try to capture that two ideas and those two dimensions of interpretability and accuracy. So what most of us would do to begin with would start with regression models and try to understand which are the variables that we really want to test, the variables that we have an idea that might be driving the heterogeneity in these community level effects. However, regression models require some ex-ante knowledge. We need to, in a way, rely on previous knowledge or some ideas that we have on which are the most vulnerable communities. And unfortunately, some of these models might be also subject to cherry picking, and they are not fully data-driven. On the opposite side of the spectrum, we have more complex machine learning model, ensemble methods, meta-learners that, however, lack that level of interpretability that is often needed when we are relying our findings to policymakers that really need to understand. We need to provide models that they're accountable. And so we came up with a solution, which is our proposed method, which is called causal rule ensemble. That is a machine learning model that retains the high level of interpretability of regression model, but also allows to test for more hypotheses that would not be testable if we were to run a regression model. And this is how the model works. We have a simple binary tree, an if-then, that, for instance, in this case would tell us if that community is a lower income community, then you should treat or not. The problem with these simple tree-based methods is that, unfortunately, they are very unstable. So if we change slightly the data on which this method is trained, we could get very different results. And we don't want that, because we want a reliable method that is highly reproducible so that the policy or the hypotheses that we provide are fundamentally reproducible. So we went for a single tree to inducing more trees and making it into a forest. So we have even more hypotheses that we can test. And after making this forest, we use a statistical method that is called regularization to reduce the dimensionality of this problem and still find these subgroups that are very important, but not providing a wealth of information that would not be interpretable. And now the interesting part, and here I have to say that we apply these to environmental data linking Medicare beneficiaries. We had data on 35 million Medicare beneficiaries and PM2.5 exposure, but this could really be applied to different sorts of data set of these dimensionalities, more dimensionality. So if you have ideas and you want to investigate this type of hypothesis, please come to me. I'll be very happy to discuss those. But in this specific case, we really looked at what was the heterogeneity in the effect of being exposed to levels of air pollution higher than the national ambient air quality standard for PM2.5 that was set at 10 micron per meter cube. And also we recorded a bunch of covariates in terms of demographic, age, sex, race, medical eligibility, smoking, BMI, and so on and so forth. We applied our method to the data, subdividing the United States into 4 regions: North, East, South, Midwest, and West. And what we found, and again, here we didn't have any hypothesis to begin with, so all the hypotheses were directly generated by the method itself, is that rural communities in Midwest, Northeast, and the South, Black communities in the South, and low-income and less-educated community in the Northeast actually were found by our data algorithm to be the one at highest risk. At the same time, we found that some minority subgroups showed some potential resiliency to air pollution exposure. This is what has been known as the potential survival bias, which might be induced by the fact that we observe people only when they enter Medicaid, so only at 65 and year older. So the most vulnerable people might have already exited our cohort. So this is a very flexible algorithm that can be adapted to many different questions and allows you to generate these hypotheses directly from the data. We have a methodological paper that hopefully is gonna get published soon. We are in the last phase of revisions. We made a website so that you can walk through the algorithm, and the R package is being highly downloaded. We have 16,000 plus downloads. So really happy about this work and really excited to be in such a great community, and I really welcome any potential collaboration on this. Thank you so much.
All right, our third speaker today is Yifeng Zhu, who's a professor in the Department of Environmental Health Sciences.
Thank you, everyone. And thank you for staying till the last panel and last talk on the Friday afternoon. And thank you for my panelists and talk about a little bit about climate change, wildfire, and air pollution. So my talk is actually combining both. So very happy to share some of the results from our research on the air pollution impact of the 2025 Los Angeles wildfire. We're going to focus today on the indoor and outdoor measurements results for both gas and particle phase pollutants. So as climate change intensifies wildfire activities, and as those wildland and urban interface continues to grow, those type of like WUI fire are becoming a very important public health issue in California and beyond. And those WUI fires, they are very different from traditional forest fires because they not just burn vegetation, they also burn our houses, electric vehicles, and household materials, plastic, everything that happens in people's house. So as a result, the smoke coming out from WUI fires contains a very complex mixture of both gas phase pollutants, such as volatile organic compounds, VOCs, and particle phase pollutant. PM 2.5, you heard about this, and toxic chemicals associated with that. And also another important point from public health perspective is those exposures not necessarily ends once the fire is over. Sometimes the lingering effects can go on for weeks and months. So to understand the impact of LA fire on air quality, our team conducted paired indoor and outdoor measurements in 25 homes near both Eaton and the Palisade fires communities. The measurements were conducted over 3 phases. The first phase is during the active burning period when the containment is less than 50%. And the second phase is still during active fire, but when the fire is contained more than 50%. And then post the fire when the fire is completely extinguished. As you can see, we measure both the particle phase, PM 2.5, and we characterize the elements and toxic metals in it. And we also measured VOCs through diffusion tubes. So this study design allows us to understand how the fire smoke infiltrate from outdoor into indoor environments and allow us also to track those pollutant concentrations change over time. So let's start with some outdoor measurements. So here you're seeing the gas phase pollutant levels, some VOCs, and particle levels, PM 2.5, and toxic metals. The gray shaded bands include the data that we collected in fall 2024 in Los Angeles, just right before the fire started. So as you can see clearly in phase 1, the PM 2.5 and also toxic metals, they're way higher than the typical Los Angeles urban background smoke pollutant levels. And some VOCs show up too, like benzene, but not all. And as the fire starts to cool down, and you can see the levels decline very quickly in phase 2 and phase 3. So this is really just showing us, like from ambient air quality perspective, the situation improved fairly quickly once the fire got brought under control. But you can see here, PM 2.5 level is high, but what is even more striking is when we start to look into the element compositions of those particles. So here we calculated something called enrichment factor. It's the level of toxic metals per unit mass of PM 2.5 during the fire over the same thing before fire. So you can see some of those elements, toxic metals such as cadmium, lead, and zinc, really increased by several fold compared to the before fire. Some other elements, such as potassium and phosphorus, they're indicators of biomass burning, also show up. So this data really suggests, confirm that alley fire did release a mixture of emissions from both the biomass fuels and the built environmental fuels. And what is probably most important is to tell people that during the active alley fire, people are not just exposed to high levels of PM 2.5, and those particles are likely to be more toxic than just the typical alley smog particles. As the story becomes even more interesting when we look into the indoor and outdoor relationship between those pollutants. So here you can see something called IO ratio. It's the indoor to outdoor pollutant concentration ratios. If the E ratio equals 1, it means basically indoor levels and outdoor levels are the same. So during phase 1, again, during the active fire, you can see across the board, those pollutants, both gas phase and particle phase, are less than 1, suggesting that outdoor concentrations are higher than the indoor concentrations, which is not surprising because at that point, the smoke is the main source outside, and people tend to stay home and close doors and windows to limit the amount of pollutants goes into people's home. But things really changed when we get to the phase 3 post-fire period. And you can see those VOCs starts to go over 1.0 IO ratio, meaning that the indoor levels are actually higher than outdoors. Those are data collected from homes that is not occupied. So that suggests there's some sources in those homes are continuing giving out of VOCs even after the fire is over. Right, the key message here is showing you that even when the outdoor air quality improved post the fire, the indoor VOC exposures can still persist for weeks and months. So to further study what's going on inside people's home, we actually collected 200 plus soft household items, such as pillows, clothes, and stuffed animals, from 10 homes in Pali and 10 homes in Eaton, and also another 5 homes that is not impacted by the fire. We brought all those items back to our lab and test them in our chamber to see what compounds coming out of it, to what level those compounds come out of it. So here are showing you some examples. We actually detected more than 30 fire-related chemicals. Here are just some examples about potential human carcinogens, iron-borne irritants, and toxic neurotoxins that were detected from those soft goods. And you can see clearly that the atoms that we collect from those fire-impacted homes are showing much higher levels compared to the atoms that we collected from those control homes that are not impacted by the fires. So taking this together is really just confirmed that the soft materials in people's house that are impacted by the fire smoke can contain those chemicals and off-gas them back to the indoor spaces even after the fire is over. So a few quick takeaways to summarize. First, the outdoor pollutant peaked during the active fire and then declined rapidly after the fire got contained. Second, during the fire, the PM levels are higher, but more importantly, they're enriched with toxic metals. So both the indoor and outdoor indicating potentially higher toxicity for those particles when people are exposed to during the active fire. And then post-fire, the volatile organic compound concentrations persist indoors, but metals did not. This is probably the most important message from public health exposure perspective, because those lingering effects can expose to people who return to their homes for quite a longer period of time, even after the fire is over. And we think those high levels of VOCs could potentially due to those off-gassing from the smoke-impacted materials. So with that, I'd like to acknowledge all the colleagues students and community partners who have contributed to this work, and the many funding sources that we were very fortunate to secure quickly to make this research possible. Thank you very much.
Thank you. So thank you, everyone, to our three panelists. If you would please take your seats on the stage. Someone has to go first. So I'm sure there'll be many questions from the audience, but I'm going to take moderator's prerogative to ask the first one. So both Kate and Yifeng, you were talking about issues of housing. Kate, you were focused on kind of housing insecurity and the impacts of that. And Yifeng, you were talking about how, there's penetration into the home environment. And I know in the context of climate change, there's a lot of kind of issues associated with housing quality and housing availability that impacts health, and heat being one other example. And I'm just wondering if you would be willing to talk briefly about what you think maybe implications are from our current housing stock and maybe need, not while we're also addressing a housing shortage, to address housing quality.
Right. So I spoke about the housing shortage, which, in many ways is sort of a climate threat, right? Because it's pushing people into areas where maybe they're not safe and where they're more prone to climate-related disasters. But at the same time, I think it's also an opportunity. There's this push to build and build more affordable housing. And I think at the same time that we're doing that, we can also make it more durable, more climate resilient housing. So I think if we have both of those goals in mind, we might be able to kind of push and advance on both of these issues at once.
Well, from my perspective, we study indoor air quality. This fire is just one of the examples, but just wants to share with the group that, inside people's house, there's a lot of environmental exposure sources that we got used to, we're not paying attention to, like, the personal care stuff, that the stove that you're burning, like for your cooking and all of those, there's a lot of indoor potential pollutant sources going on in people's home. So I think when we're talking about housing, this is also, some of those public health education pieces, awareness, and people really starts to get to know it. I actually think the fire bring some sort of like silver linings. People start to realize the importance of the indoor spaces where people spend more than 90% of our time in right now inside this auditorium. And so we really have to pay attention and keep that in mind as part of the environmental health and broader public health topic.
Volker, do you want to comment? Okay, questions from the audience? Yeah, there's one right here.
Hi, I don't really have a question. I guess I have a suggestion. Because this is housing, conversation about housing mostly in this panel. So as I mentioned earlier before, I am a researcher working for the federal government, and part of my job with the federal government, not only to do in-house research, but also look into what we call data license application. That is when academic institutions ask us to share data, and specifically housing data. And so if you request data from the federal government on housing, I will probably be looking at your application. And I just want to mention, the person before, and from the panel before, said that she requested data and it got denied. And I just want to comment on that because this is sort of what kind of part of my job right now. That people who request data from the federal government have to kind of think how they ask for the data and what language they use. For example, if you request data for climate change, housing and climate change, that's probably not gonna go well. But if you said you want data about extreme weather patterns, that might be okay. And the same goes for equality, equity, and all these keywords. we just had to deny application last week for somebody who submitted data for their PhD dissertation research. And I don't know what that person is going to do. Maybe she has something else. But again, because she had all these key buzzwords, like there's no way it was gonna be approved. And it's not like I'm not approving or denying it. It goes, and people not gonna approve it.
Yeah. Well,
So I just kind of want to point this out. So when you want to request data, federal data, you kind of have to be mindful about what you're putting in your request.
Yeah, thank you for the comment. I know a number of us have had internal discussions about code switching that we use when we talk about our research, and it's unfortunate that the student wasn't counseled about that. But maybe you guys could talk a little bit about how this new prohibition or taboos talking about climate change and the anthropogenic causes of climate change have shifted the way you talk about your research.
I can give a quick answer. That's why we go ahead and collect our own data.
No other comment? This is. Yeah. Another question from the audience? Brad, do you have?
Hi, thanks. Great presentation. Scott Camulata, Health Policy Management. I guess this question is directed more towards Falco. And first want to say love Florence, was just there a couple weeks back. The methods you were talking about as you were presenting them, and certainly very applicable to the environmental sciences, but also thinking about so many applications in these ensemble machine learning methods and causal inference outside of that, including health policy management. How do we learn more about that ourselves, direct students, obviously to take your classes, but what are good resources? Because I feel like those methods are just so applicable. We should be using them more and learning about them.
Yeah, thank you so much, Scott. I think that's a very important question. So let me start off by saying that at least the way I think about these methods, but more generally artificial intelligence methods, is that they are not to be, we still have to design a good study. We'll still have to make sure that all the right pieces are in place. And after we have designed a good study, we have properly done randomized controlled trial, a good observational study. At that point, I think there is a possible added value of running this algorithm. But I think the first thing, it's a little bit of a cautionary tale on my end to say that this is not a replacement for doing all the type of good scientific work that we have always been doing. I think there is an additional value once you have a well-designed study in using these techniques that some of which I've introduced here. I think one of the things that are really good at is like really generating a hypothesis for us, hypothesis that maybe we would not be thinking about, stuff that maybe goes to a level. For instance, it's easy to think about, there is one variable that I might test for, but what about interactions within variable? That type of problems become very, very hard to solve as human beings. And this is one thing that these methods do very well, do much better than we do as humans. However, I think, again, like the careful thinking about how we design the study, how we think about this question from a causal perspective, all those things should not be given away. So we still have to think carefully. And then there are some perks of this. And right now, it's a resource that is more and more available. There are packages such as the one that I release that are there. But there is also, I think, a lot of confusion. I think we're at the point where the noise is larger than the signal in a way. So navigating this, it's pretty hard, even for people like myself who does this for a living. So I think there is a lot of noise, and we need to be very good at parsing out the noise from the real signal. And for us to do that, I think there are great resources out there. I'd be happy to share them with you and with the audience on like where to find good stuff. And I think also the way we think about our curriculum as statistician, biostatistician, it's important, and probably starting to introduce that in our curriculum very early on. I think that would be something that would really give that knowledge share the knowledge with the students, with the practitioner, so that we can start to navigate. Because at the moment, it's very hard.
Brad, or did someone else want to reply? Or?
Yeah, hi. In one of the last couple of slides on the post-fire toxins, the toxins were higher, they dissipated more quickly outdoors, but they persisted indoors. In that, in coming to that conclusion, did you control for remediation efforts, or is that in the absence of remediation or despite remediation?
That's a great question. Thank you for asking that. So the data collected that I'm presenting today was collected in February. That's before any remediation has ever done on those homes that we tested. Right now, we are actually planning to go back to the field again. Like we'll finally get a NIH rapid funding going through. It's been a year, but finally go through the rapid the rapid R21. So allow us to go back to the field and test again. And at this point, we're actually planning to test exactly answer your question. So what remediation actually worked and which didn't work. It's been well west from the fire survivors, and people are sharing all sorts of information they got and all sorts of remediation practice people have engaged. And I'm actually very curious about like what really worked, to what extent it worked. So we're planning to continue on that research.
Following up, this is Eric Wilkes from the Fielding Finance Development Office. Sorry, Yifeng, this is actually a follow-up. The sensors that you still have on the locations of the fires, are they still picking up air data, pollution data from the fires?
So the Palisade network?
Yeah.
Yes. So there's actually two networks. Caltech colleagues set up a network in the Eaton fire burn zone. It's called Phoenix. The UCLA funded by King Foundation and then the Dana Foundation, and allow us to set up this network going on in the Palisade and the West LA, Santa Monica area. So that network is still continuing. As is well received by the local communities. We're getting lots of emails and appreciations, and just like say how people use this data in real time to get their daily activities. And then if any sensor went down, we got message, and my postdoc went out, I fix those sensors all the time. So really been very rewarding experience, and being able to support the community with some real data and to help them get their decisions post-fire. Yeah.
Jack, Brad's coming too.
Jack Needleman, Health Policy Management. Fascinating studies. One of the things that struck me about the designs here was how different they were. That the study of housing, the study of the wildfires are, what economists would call looking at exogenous shocks. And the shock is so great that at least in Yifeng's work, we don't even need a comparison group. We can just look at the levels against what's considered norms from other places. Your work was cross-sectional. And I was wondering if we could get some reflection from each of you about the value of cross-sectional work in understanding the impact of environmental variations in environmental impacts and the potential application of that to looking at the effects of climate change over time. And likewise, for those who have been looking at exogenous effects, the shocks, what the value of continuing to look at studies and the limitations of looking at studies that focus on taking the natural experiments of the exogenous shocks of wildfires and similar extreme weather events.
Great question. So as I said before, I think all the usual caveats when you want to do a very solid causal study would be here at the same time. Like what I mean by that is, for instance, in our case, it was a cross-sectional study. So what we needed to do is really control for all the potential confounding factors, account for them so that our exposure, people that are exposed to higher and lower level would be as good, would be a fair comparison. Whether that's true or not, I think it's a matter of like, have we collected enough variables that might confound our causal claims, which I think in our study, I think we collect a lot of things, and also we are very careful in running a sensitivity analysis. And I'm getting a little technical here, but what we really wanted to say, if some of the underlying important assumptions on which our study is based are failing, can we still say something? And in our case, the sensitivity analysis returned to us were pretty strong. The signal was pretty strong, and so I really believe that there is something in our study. So on the opposite side, when we are also looking at the heterogeneity, the things get a little bit more complex, because you could think that maybe some groups that are more structurally exposed to certain pollution, then the heterogeneity in the effect comes from this structural exposure. So there are certain limitations. I agree that cross-sectional studies are a way to analyzing this type of data, but if you wanted to even move beyond that, I think having some quasi-experiments and exogenous variation could also help us do that type of analysis. I know that, for instance, in the space of air pollution, in terms of quasi-experiment, looking at the direction of air pollution, changes in the wind direction, or exogenous change, such as like, we will have an amazing exogenous change here. I'm really excited. The Olympic Games in 2028 are going to be an exogenous change because we cannot use our cars, yay. But that will reduce the level of air pollution, so I'm ready to collect those data and see what happens.
Yeah, I'm glad you mentioned the early 28. Like actually, our school has a task force just formed up to tackle that. So it'd be nice to collaborate. And I really appreciate the event, because I never know that I have colleagues in Bellstat like doing exactly the same type of work with me, where we have ongoing work and focusing on California. So definitely should talk more. So environmental health, we love natural experiments. A lot of natural experiments has been done, and it's just really giving very interesting results. And as an experimental list, I like to design the study so that I have controls, positive controls, negative controls. So I know the data that I'm collecting really makes sense. And one thing that I learned from this early fire experience is that the data really don't lie. Data don't lie. Just don't torture the data too much. The data don't lie. And we see something, sometimes it doesn't make sense. We don't know where it comes from. But at the end of the day, like when we solve the puzzle, it all makes sense. The data are really interesting. Like for example, I didn't get time to share everything here, but we're also seeing something very interesting, that the metal levels in the air sample we collect versus in the dust sample we collect showing up very different patterns. But at the end of the day, it all makes sense because it's all related to how those metals they behave. Their their physical properties or chemical properties make them to be more enriched in the airborne particles versus the dust. So lots of those, it's not like a cross-sectional study design, but I think that design also serves its own purposes. Lots of the studies, when they first start, like you don't have the resources to do a longitudinal or like a well-controlled study design that cross-sectional can give some good insights, I would think, and then help you form a good hypothesis, then design even more robust method to tackle the questions, in a deeper level.
I'm not sure I have anything much to add, but I think some of the descriptive stuff that we're doing in shelters for people experiencing homelessness, not at all causal, but I think it's really important. It's a location that we expect, shelters are often pushed to the margins. People build them wherever they can, and against tremendous kind of NIMBY pressure, for the same reasons we can't have affordable housing in well-resourced, healthy places to live. Like shelters for people experiencing homelessness are often pushed out to neighborhoods that have really, really bad environmental exposures. So I think just documenting sort of needs for interventions there with these cross-sectional, pretty simple data is super worthwhile.
Okay, we have time for one more question in the front.
Thank you for your talks. Dee Walters. I would like to ask about the difficulty of teasing out specific exposures in non-emergency situations of people who may seem to have been exposed to the same things or grown up in the same area, but spend different times of their day doing different things. So I'm a transit rider. When I leave here, if I leave campus at day's end and I take the number 2 bus, which will turn eastbound on Sunset Boulevard, I will proceed through some of the nicest neighborhoods in the city. And because of the hour that I'm leaving, most of the people who will board the bus will be ladies who have cleaned people's homes all day. They often live in zip codes that are not so nice zip codes, have a very long ride home, and indisputably they have done a very long day of hard work. But they've done their long day of hard work in a nice neighborhood inside a nice house. Their husband or their son may live in the same house at night, in the same house in the same zip code as them, but he may be, if I pull it, just a random job out of my head, he may be a roofer, and he may be exposed to an entirely different set of circumstances and chemicals, both because he's on top of a building all day, even in the best of circumstances, and the materials that he's exposed to. Or, for example, I grew up in Boyle Heights, in the entanglement of freeways. All the cloverleaf freeways is where I grew up. Those were my formative years as a child. But as an adult, I did not live near any freeways at all. So how do you tease out what would seem to be people that are advantaged, disadvantaged, where they're living, where they used to live, and what their lifetime of exposures may be?
That's an excellent question. It's almost like a lecture for an introduction for environmental exposure assessment. Like you really touched upon all those key concepts, right? Like time, space, frequency, levels, and occupation, residential, neighborhoods, personal exposure. You cover all those key elements in the environmental exposure class introduction lecture. So thank you for that. So indeed, like, we're talking about fire exposure, but freeways and mobile source emissions, occupational exposures to the cleaning products, and the lady that you mentioned, like transit, like when you're commute, stuck in freeways and in buses, you get high levels exposure to those traffic-related air pollutions. Depends where you live, where you work, the hours where you are and what you're doing all affect your cumulative exposures. And it's the cumulative exposures that determines your health effects. For sure, I think thank you for that question.
Yeah, you highlighted an area that's a significant area of research in our field, and I would love to say we actually have a great answer, but there has been a lot of work, like by Dr. Jarrett, who was here earlier in particular, who studies like, how do you account for the movements of people over the course of the day, and how do you incorporate that? And as Yifeng said, this is an area of active inquiry that I think is a real challenge for our field, because really our epidemiologic studies are quite crude, right? They might take your residential address and that's it. And that's how most of our environmental health research had been done. And we're seeing a transition in that over the last 10 to 15 years that will continue to begin to get to improvements to answer questions at that level of detail. But in the interest of time, I would like to thank our panel for their participation today. And turn it back over to Ron and James.
Well, thank you all very much. This actually brings us to the end of our formal session, but hopefully not the end of the conversations. We'll be having a reception in the lobby immediately following. I would just say that, this really fulfilled our vision, what happened today. And just thinking about the last panel, how we had faculty from 3 different departments, and there were a lot of commonalities and different study designs and different measurement issues. But I could see the spark of a lot of collaborations and connections, and throughout the day, I think there are a lot of opportunities for us making connections with each other. So from my end, it was a terrific success. Before we formally adjourn, I want to express my sincerest thanks first to our incredible faculty who both moderated and presented today. Thank you so much. To Dr. Erica Pan for her keynote address, which was terrific. And actually to all of you for being part of our Research Innovation and Impact Day. And for those of you who are here, and also for those of you who are online, thank you for being here. Your presentation, your presence today really strengthens our community, so I'm very grateful. So with that, let's continue the conversation, and please join us now in the lobby for some light refreshments and conversation. Thank you.